Good morning, everyone, and thank you for joining us for today's event for the East London Community Mental Health Transformation event. Just before we begin, we just wanted to explain some of the functionalities of this Teams live event. Thank you. So just to let you know that to ask any questions during this event, you will need to click on the small symbol with the question mark highlighted here with arrow number 1. If you click on this box, you will be able to ask any questions you may have. There is an option to either enter your name, or if you would prefer, you can click on the small blue arrow, which will allow you to remain anonymous. We will have people monitoring our Q&A box, and during this time, they can either respond to you privately or they may wish to publish the event. Please do keep an eye out for some of the questions that may come through in the Q&A box. And if we do have any technical difficulties, we will alert you to these in the Q&A box, and you may need to just bear with us for a few minutes as we sort ourselves out. But we thank you for joining us today, and we hope you enjoy this event. And we would like to present Richard Fradgley, who will give the welcome. Thank you.
Good morning, everybody. My name's Richard Fradgley. I'm the Director of Integrated Care for East London Foundation Trust. I'd like to extend a very warm welcome to this workshop on the work we've been doing to transform community mental health services in North East London. This started off as an opportunity to share some of our learning to date with colleagues from Positive Practice in Mental Health, but we've extended it a bit, and we now have colleagues from London and East of England trusts and STPs, NHS England, Health Education England, and other colleagues from across health and social care. So a very warm welcome to all. I'm just going to quickly hand over to Dr. Paul Galuli, our Chief Medical Officer, who's also going to say a few introductory words.
I think I'll start off with saying a huge thank you. Actually, we talked about this a couple of weeks ago, to talk about having a get together with Positive Practice in Mental Health to look at where we were with community transformation, and the team, I must admit, has gone above and beyond in putting together a fantastic programme for today. So thank you first for the team for doing this, and I'm really excited myself to find out more about the work that's going on and more detail about that and hearing from the ground all about it. So thank you for the invite. Can I welcome along Angie Russell from Positive Practice in Mental Health, who's really shown an interest in this with her and Tony from the start. They're really interested in how we can improve our community health programme for service users, and how we can spread that amongst the other collaborators in Positive Practice for Mental Health. So I hope Angie and Tony get a lot out of today as well, and can take that and start spreading it wider across what we've actually gained, what we've successes we've had, and what challenges we face, which I'm interested to hear about as well. So thank you, Richard.
Thanks, Paul. So just a few words of introduction. So at ELFT, we're really proud to be the lead organisation for the early implementer site in North East London. It feels to me as if this is the most significant opportunity to transform community mental health services that we've had in 20 years. I don't know how many people remember the National Service Framework for Mental Health, but that was the last time, and it really was 20 years ago. This transformation comes at a time when it feels as if it's very much needed. COVID-19 has clearly had a massive impact on the mental health of the communities we serve and on the way in which we provide mental health services. But service users and carers have been telling us for a long time, really, about the gaps and issues in our current approach to community mental health, and the immensely creative and forward-thinking national community mental health framework and the £1 billion, just short of £1 billion worth of investment that the long-term plan brings with it into community mental health services. This is our way in to addressing some of those long-standing gaps and issues. We don't think that this is about adding on additional services to bolster the gap between primary and secondary care. Fundamentally, it's a root and branch reimagining of what new neighbourhood mental health care can be, developing these primary, secondary and social care and voluntary sector blended teams around people and communities of 30 to 50,000 and really importantly, creating teams which are good places to work, fun places to work. So our programme is using the tools and techniques of quality improvement, involving service users and staff to identify the change ideas that will make a difference on the ground, to test them in pioneer primary care network mental health teams, and to scale up those ideas where they work and to learn from them where they fail. As you'd expect, we're discovering many varied, complex, detailed operational, clinical, cultural and governance and process questions that we need to answer as part of this transformation. And we certainly do not have answers to all of those questions. So today we're really looking forward to sharing where we've got to, the triumphs and some of the conundrums, which we're hoping to be able to work through with STP and regional partners over coming months and years, really, through to 2023-24, when the final service development funding for this programme of activity kicks in. If we could just move on to the next slide. So we've got a really full agenda with lots of speakers and perspectives. We have service users, GPs, psychiatry, social workers, psychologists, and new and fantastic community connectors, all talking a bit about where we've got to along the themes that you can see in front of us on the agenda. We're intending, there's a lot here, as you can see, we're intending to try to stick to these times. So we're going to do our best. We're going to do our best with that. Just also to say that if you use Twitter, we have a hashtag, which is hashtag ELConnect. So if you are Twitter minded and you feel like tweeting about this event, then please do so. I hope you enjoyed the session. I'm going to hand over to Jamie, our programme director, who's going to initiate the first session.
Good morning, everybody. My name's Jamie Stafford. I'm a senior programme manager working in the Community Mental Health Transformation Programme, and I'm going to be giving you a little bit of an overview of the programme, but I'll also be kind of walking us through the various sessions during the day. So again, sending out a huge welcome. Thanks for coming along to hear more about what's been going on. Really excited about the presentations today. I think there's just such a rich amount of content, and I hope that by kind of bringing it from so many perspectives, it'll be of use to people embarking on similar journeys. Can I have the next slide, please? So Richard mentioned the community mental health framework for adults and older adults, which came out last year, and within it really details the direction of travel for where we'd like to go with our transformation. And just on this slide, you'll just see, I'll not go through them all, but some of the real key aims and objectives for what we as a system want to start to try and do: dissolving boundaries, better integrating, thinking about populations and population health, and really moving beyond diagnosis solely as our way of organising care, and thinking about specific groups that historically have had a poor offer, and looking to work with those groups to improve what they can expect and the support they get. So I'll not go through them all, but the vision, I think, was really laid out in this framework beautifully. It really helps give a way to approach and think about some of the change, the case for change, and some of the ways that we might start to improve how community mental health care is structured and delivered. Can I have the next slide, please? So our approach back a year ago was to think, as we embark on this complex, messy transformation and change, what are the guiding principles? What are the design principles we'd like to be true to? And we generated this list of 5 things that were really important to us. It's that service users and citizens are going to be active and equal partners, and I hope today that's the impression you'll take, is that we've looked to work with service users and citizens in design, implementation, governance and delivery of what we of our new care model, which is, as Richard points out, is still in formation. We don't have all the answers at this stage, but this is something that's really important to us. The next one is about this integration of mental and physical health, well-being and social care. And again, I hope today that you can see that our attempts are to bring together lots of different organisations and different strands of people's the support that people access and better integrate them. Having the right support in the right place at the right time, and this really speaks to the PCN, the primary care network footprint. So populations of 30 to 50,000. It's how are we working with communities to make support available so that people aren't bounced around across boroughs and people aren't people are able to access the right support closer to home. Focusing on what matters to service users is obviously crucial, and we'll kind of talk about how we've gone about that during the session at different points, but making sure that what we offer is about what matters to service users, not solely what services are set up to deliver, but that this really speaks to what individuals, what matters to them. And finally, about having evidence-based interventions being a really kind of key design principle. Can I have the next slide, please? So this is our driver diagram, and over on the left-hand side, you'll see our aim statement that we as a programme, we want to deliver what matters to people who need mental health support in East London, and that we've, through our work, iterated this, but that we think that these primary drivers lay out some of the really key factors and themes within that work. It's so in this middle column, you'll see the 7 key primary drivers that we think, if we get these things right, then we'll go some way towards delivering what really matters to people. And then further breaking those down on the right hand side, it's started to lay out what really are some of the key bits of work and some of the key focus of our program. So in places that's around infrastructure and systems and IT, and in other places it's more around thinking about complexity and thinking about wider determinants. And it's I reflect on this and think of this aim being really requiring a really diverse and broad amount of work and different focuses, and lots of different folk need to come together to deliver this. And I hope that today we can give you a bit of a cross section of lots of the people who are really focusing on this currently. Next slide, please. So a bit of an overview of some of the numbers, so that where we're up to. We currently have 75 members of staff who are in some way working in the programme, although really it stretches beyond that, because there's lots of people who are involved in the work, but not necessarily paid through the programme, but it's through their normal roles. So that's a combination of associates in community psychology, some community connectors we'll be hearing from more later, these new roles. We have GPs and peer support workers. We've got we've got 11 out of the 26 primary care networks that are currently involved in some sort of testing of new approaches, and they're listed there, but that continues to grow. We've got lots more primary care networks joining currently. We've been able to fund a whole range of projects of all sorts, so lots of different pieces of work that have been funded through the programme, and we've just dozens of organisations involved. Again, you'll be hearing from a few of the different voices today, but including CCGs, local authorities, NHS trusts, voluntary sector organisations. Next slide, please. So, as Richard mentioned, we're an organisation in ELFT particularly, but other organisations in the area too, with a proud history of quality improvement. And testing and having an approach to testing change ideas in a small scale test, and spreading what works and not spreading what doesn't work. And that's really what how we've approached this transformation too, is that we've been looking to test out different ideas. And again, I'll not go through them all, but a really broad range of things, from having days when a secondary mental health service, so traditionally a CMHT, will just accept every referral. And what does that mean? What impact does that have, and what can we learn from doing that for a day? What do we find out? From a GP and a consultant psychiatrist to go for a coffee with a service user and not have a clinical conversation, but to talk about life. What does that do? What happens then? And what can we learn from it? And what can we spread about what works there? But as well as that, use of different clinical record systems and finding ways to test those out have been really important. And different processes, we're using the Dialogue Plus care planning and assessment tool in our secondary services already, but what about if we start using it in primary care? What happens if we try and use some of our tools in other contexts? So there's a whole range of testing going on today, and you'll hear a lot more about those during the day. Can I have the next slide, please? And as well as the local small-scale testing, if you like, there's also a selection of things that we're calling our program library, which are things that we want to do once and get right across the patch. Because as well as having some locally defined and locally tested pieces of work, there's something about how that local learning feeds in and starts to shape our approach to things like assessment and care planning and complexity and waiting times and governance. And over on the left, you'll see some specific populations that are highlighted within the framework as groups of people that historically haven't had great experiences. So there's how are we working with those groups? And again, you'll hear more from our disordered eating pathway and our complex emotional needs pathway work, some of what's been going on. And then next slide, please. This is a little bit of a reminder to those old days when we'd all be in a room, and our approach has really been to try and bring people together to test these things and come up with answers. And it's great to have 30 presenters today from right across the patch to bring their experiences. It's really been important to us that we try and reach into a wide group of people, a wide group of stakeholders, and you'll see some pictures here from our learning sets and workshops when we've used the time to try and develop some of our ideas and test things out. And you'll see the top left and bottom right, we've had to move to a bit more of a virtual approach in the last 9 months or so. But still, we've been looking to find ways to really connect with the people that we know that are better placed to answer the difficult questions than in a corporate office. It's really about reaching into those service users and staff that properly understand the point of care and what's going on. So a big part of our approach has been about how to engage the right people in this, and I hope, as I say, there's a good kind of cross section of them here today. So without further ado, I'm going to hand you on to our next presenters. Becky and Iram and Sam are going to be talking to us a bit about people participation and what our approach has been around that. So Becky, I think over to you first.
Thanks, Jamie. So yeah, as Jamie said, I'm going to be talking a bit about our approach to people participation in the transformation programme and what we've learnt, and you'll also hear from two of our new people participation workers. Next slide, please. Next slide, please. So as Jamie mentioned before, so one of the stated aims of the transformation programme is that service users and citizens will be active equal partners, leading the design, implementation, governance and delivery of our new model. Basically, we want service users and carers, the people that these services are actually for, to be as involved as possible in developing these new services. Next slide, please. So far, as you can see, service users and carers have been involved in a wide range of activities. So you've got your borough level groups like clinical governance, clinical systems, things that are going on in the boroughs, like the development of the complex emotional needs pathway, the borough level steering groups, also various focus groups, learning sets. There's service users involved in the evaluation of the project and of the programme, and the kind of intention for that is that a researcher in residence will work with peer researchers to do the evaluation. Service users have been involved in 100% of recruitment to the programme, and have been involved in developing the new care model. Next slide, please. So I'm just going to talk quickly about one of the kind of programme products, I guess, that we've been developing, and this has been quite a sort of big standalone piece of work, and we've put a lot of effort into working with service users and carers on developing this, by way of three focus groups back in March before COVID hit, and we were lucky enough to be able to do things in person, where we talked about so this is the 4-week waiting time standard, which NHS England have asked us to sort of define how what we would like to do within 4 weeks of somebody being referred or accepting that they need support. So the idea is that we'll test a 4-week waiting time standard, and it's about what's acceptable, appropriate, and a meaningful care intervention. So we've been doing some work with service users and carers to have a think about what that is. Next slide, please. So this is just a quick sort of diagram of the current model in comparison to the new model. So what we're working is, you know, the clock starts on day one, someone requests or is offered help, and there's this period of 4 weeks in which an appropriate care intervention should happen. So we've been working with service users and carers to find out what that care intervention might be, and how would we know that it's been meaningful. And that's actually a really difficult question to answer, but we had a go. We wanted it to be something a bit more creative than just saying full psychosocial assessment. So if you go over onto the next slide, please. So these are interventions that service users think are appropriate, so meaningful, valuable, and acceptable. So I won't go through them all. Basically, these are mapped to the 9 domains in the Dialogue Plus assessment. So the idea is that through the Dialogue Plus assessment, somebody would identify which areas they most need support with, that are most affecting their lives. And so a lot of this is actually things that are not, you know, wouldn't be considered part of a more traditional mental health services model. So, for example, you know, an appointment with a psychiatrist, or even, you know, a psychologist. There is lots of stuff in there about psychological therapies, but there's also really practical things like, you know, benefits advice, career coaching, referrals to housing support, relationship counselling, self-defense classes, peer support groups, lots of other things that sit outside the more traditional mental health offer. And this is kind of what we're hoping to be able to deliver with some, you know, with our new peer support workers and community connectors. Next slide, please. So that's just one standalone piece of work that I just wanted to capture, as there have been a lot of service users and carers involved in that piece of work. We did a review of people participation in the programme back in June. Up until now, a conservative estimate, I reckon about 60 individual service users have been involved in the programme to date. It's actually probably more than that. Service users and carers have been involved in all the recruitment of staff. COVID-19 and digital exclusion has had a big impact on the continuity of some groups, and therefore the involvement of service users and carers. A lot of stuff has gone online. Obviously, that's not ideal for some, service users who don't have the equipment to get online or an internet connection. Although we have tried to combat that with a change in our reward and recognition policy, and we decided that the programme needs to direct more resources towards the involvement of carers, Black, Asian and minority ethnic people, and people who use services in primary care and the voluntary sector. We wanted to build on the success of people participation in the disordered eating pathway, where there was a dedicated expert by experience working on doing focus groups and one-to-one interviews with service users using the current service at St Anne's, and you'll hear more about that later on. Next slide, please. So in order to build on that, we decided what we needed to do was bring in 6 new part-time people participation workers, and these roles for people with lived experience as a mental health service user or carer. So the 6 roles were Black, Asian and minority ethnic access, disordered eating, carers, complex emotional needs and trauma-informed care, older people and young adults. So the carers and older people are a different colour because we weren't able to recruit to those posts, unfortunately, but we're going to have another go at that soon. You will hear from Sam, who's the Black, Asian and minority ethnic access people participation worker shortly, and Iram, who's the young adults PPW, and Catherine, the disordered eating PPW, and Sinead, the complex emotional needs PPW. You'll hear from them in later presentations today. Next slide, please. So the idea of the people participation worker role from the programme's perspective was to increase meaningful participation of service users and carers from their target group in the programme, including service users in primary care, local authority and the voluntary sector, to facilitate participation meetings and establish effective structures that enable service users and carers to express their views and participate in decision making. So that might not be in the traditional ways that we might do people participation in other areas, and it's up to the people participation workers to work out how it's going to best happen with the group of people they're working with, and to work with local community organisations, service users and carers to develop services that meet their specific needs. From the team's point of view, it allows me to focus on the strategic overview of service user and carer involvement, enables recruitment of staff who better reflect the lived experience of that target group, and also it brings in some entry-level people participation roles, supporting career development and service user and carer leadership. Next slide, please. So I'll hand over to Sam next, and then you'll hear from Iram, and then it will come back to me just to wrap up. Thank you.
Morning, everyone. My name is Sam Koya, and I'm the BAME People's Participation Worker in the Community Mental Health Transformation Project, working in Newham, Tower Hamlets and City and Hackney. I just thought before I go on, I could give a little background on the incentive or why this role exists in the transformation project. Next slide, please. So it was a really interesting paper by Frank Keating on circles of fear. I'll just read through it quickly. There is a compelling research and statistical evidence which shows that Black and African Caribbean people are overrepresented in mental health services and experience poorer outcomes than their white counterparts. Stereotypical views of Black people, racism, cultural ignorance, and the stigma and anxiety associated with mental illness often combine to undermine the way in which mental health services access and respond to the needs of Black and African Caribbean communities. When prejudice and the fear of violence influences risk assessments and decisions on treatment, responses are likely to be dominated by a heavy reliance on medication and restriction. Service users become reluctant to ask for help or to comply with treatment, increasing the likelihood of a personal crisis, leading in some cases to self-harm or to harm to others. In turn, prejudices are reinforced and provoke even more coercive responses, resulting in a downward spiral, which is called circles of fear, in which staff see service users as potentially dangerous and service users perceive services as harmful. So I know that this isn't new information, but I just thought I can give a little background to that. And then just to go to what some of the issues are. Next slide, please. So the issues, first one being the overrepresentation in services, given the fact that in the UK, only 8% of the population are Asian and 3% are Black. This suggests that social issues like poverty, stigma, and racism might explain the overrepresentation in BAME people when they access services. Treatment in services. So negative experiences when admitted may lead to feelings of distrust, for example, forced medication, restraints, and the way people are spoken to, which moves us on to accessing services. We know that there is inequality in the BAME people accessing healthcare and services at an earlier stage. There's been some interventions for that in the past, but not something that's been reoccurring. So the social barriers, when we talk about the costs, when we talk about the availability of being affordable, attainable, these are things that we should strongly consider as well. Misdiagnosis and medication, the misunderstandings of behavior can often lead to misdiagnosis, and therefore there's a lack of consistency in medication doses and over-medication in the BAME community, which leads me lastly to talk about the culturally irrelevant services. Services and therapies tend to cater to white and Western populations, which means that they are often not relevant or applicable to the BAME community. Just worth saying as well that the paper by Keating is also applicable to Asian and other minority groups. My role, next slide please. So my role is to build up a network of BAME service users and recruiting participants. So we'd also like people from the community, but as these are maybe people who may be reluctant to access these services, is to promote awareness, so liaising with community connectors and other third parties, PCNs, GPs, PPLs, psychologists, amongst other professional bodies, to co-produce focus groups with service users. So I believe working together and generating ideas through meaningful dialogue is a great method. Therapy, so thinking about new ways of working and receiving therapy. As I've mentioned, services are not culturally relevant. And to empower service users to transform services. So how would we do this? Through auditing, giving feedback and discussing underlying issues, retrieving data as a result. So links. We have links with community connectors all around Tower Hamlets and Newham, and the African and Caribbean Heritage Project in Hackney. We are constantly and currently working to improve all the contacts we can get as much as possible for the project. Next slide, please. Which leads me lastly to talk about my aims and objectives. So the first one would be to action change, to make sure people's voices are heard and have a more proactive approach. I don't want this transformation project to be cliche. This is a reoccurring topic, but it's good to talk about these things and have the main objective be to try and make change. Secondly, social inclusion, to change the way services are run, to include everyone, and to help improve engagement to these adapted services over a long-term period, hopefully. And last but not least, to design and test new ways of working, to implement these interventions so they become attainable and part of services we render in future so that the changes are sustainable. So that's my take on here. I'll pass over to my colleague, Aaron.
Hi everyone, my name is Erin Weller and I am the pupil participation worker looking at young adults in particular. So when we talk about young adults, we're referring to the 18 to 25 age group. Next slide, please. So just a background to that work. We've identified young adults as a population needing a specific focus as part of the transformation work. Firstly, Tower Hamlets having the highest proportion of young adults in London really highlights why it's important for us to think about the specific unique needs of young adults, so that we're not kind of leaving out such a large proportion of the population. We know already that sometimes young people feel that services don't get it. Sometimes people feel kind of the way they're spoken to isn't in a way that is relatable to them. Sometimes they're not offered the interventions that they might want. So, for example, as Becky highlighted before, sometimes it's not all about medication or psychological therapies, but some young people might prefer peer support where they can talk to other young people who get it. Sometimes they might want support with engaging with education, training, getting into work, stuff like that. Sometimes there might be problems at home in the family, so it might be looking at social support around that and involving social care if needed, or supporting them to become more independent as they go through all the many changes that you go through during kind of adolescence and up until 25. We've already made some connections with many young adults through the 18 to 25 Young Adult Co-Production Group and the Newham's CAMS Transitions Project. I've also been liaising with many of the ELFT services, which work specifically with 18 to 25-year-olds. So, for example, things like the Tower Hamlets Early Detection Service, the Early Intervention Service, and linking up with some young people who are interested in the transformation work so that we can hear their views. And as Becky and Sam already said, really make sure that we're hearing what it is that they actually want rather than assuming that we know, and making sure that those themes that they highlight to us are really prioritized in how we redesign the service. There are already several young adults also involved in the new complex emotional needs and young adults pathway development. So that's just another way that we're involving them in the kind of right from the start rather than just at the end, really remembering those co-production principles of involving someone as an equal right from the start rather than it just being a mini consultation at some point or the other, or a mini feedback kind of session at one point and the other. It's really trying to co-produce as much as possible, whilst really valuing the input that young adults give us by, for example, things like the reward and recognition policy, by offering things like training opportunities to the young adults who get involved with the participation work. Can I have the next slide, please? So yes, looking at the aims for the next few months, we want to meaningfully involve more young adults with diverse needs and from diverse backgrounds in all aspects of the transformation programme. Working with peer support leads to develop peer support offer for young adults and career pathways into peer support, just because that's something that has come out of some of the consultations and conversations that we've had already, that is something that many young people would find of value. Also, there's a Young Adults Access project that begun with Tower Hamlets Recovery College. Another thing that we're looking at is the CAMS to adult services transition. So the transition for young people who go between child and adolescent services and adult services. And we're looking at how to avoid the cliff edge, which has been spoken about for many, many years. But as Sam mentioned, we're really trying to not just talk about it anymore, but actually do something. So, do we need to reconsider the commissioning, or do we need to reconsider a transition support worker, or do we need to reconsider the different kind of eligibility criteria for these different services to make sure that people aren't turned away at whatever point they need help, and also for us to really kind of keep in mind the kind of how common it is for people to develop mental health difficulties for the first time during that sort of age. So, it's, very common age for people to develop difficulties at around 17, 18. And if that's the point where, you're not sure whether to put them in CAMS or adults, then that's a big problem. And we need to think about how they can get consistency and continuity of care. There's also I'm also working with the peer participation worker for disordered eating, Catherine, to develop training around body image for schools and higher education. So again, looking at or liaising with both the complex emotional needs pathway and disordered eating, obviously recognising that there's a big overlap in terms of the young adults in those sort of other subgroups. And yeah, I'll pass back over to Becky.
Thanks, Iram. Thank you, Sam, as well. So we have some plans for the people participation work in the transformation programme as a whole. One of the projects that I'm working on is creating a pool of lived experience trainers. So co-developing and co-facilitating mental health training for PCN staff on a variety of topics. So co-delivered by people with lived experience, either as a service user or a carer. And we have two trainer courses running with Tower Hamlets Recovery College to skill people up in order to do this. And so by the end of January, we should have 15 people trained up. We're going to be offering lots of skills development opportunities for service users and carers, again, helping people to get skills they might want or need in order to get more fully involved. So, for example, training to be on interview panels, training to chair meetings, and of course the trainer course I just mentioned. We'll be working with the patient participation groups in primary care networks to try and get more people who use primary care services involved. We're working closely with the community assistant psychologists, the community connectors and the peer support workers to develop the services that they're offering. We're supporting local user-led organisations and other service user initiatives. And this is part of delivering what actually people really want and what really matters, and supporting service users to lead their own projects. Jamie talked a little bit about the programme library earlier, so we'll have service user or carer leads for all of those products in the programme library. We're going to start having a greater focus on the involvement of carers and older people going forward as well. So I'll wrap up there and hand over to Jamie. I will put the email address for the team in the chat if anybody has any questions and would like to get in contact with us. Thank you. Over to Jamie.
Thanks, Becky. And there are just a couple of questions that have been coming in, and I just wonder, I don't know if you'd like to answer them directly or in the chat box, but there's a couple of interesting ones about how can we make services more culturally sensitive and what changes are needed, and another one specifically around BAME transformation development and how this work's being mainstreamed at all levels of the system. I don't know if either of you or any of you would want to pick up those before we move on.
I think probably me and Sam will have a go at answering those in the chat, if that's all right.
Of course.
Thanks.
Of course. Fab. Thanks, guys, and yeah, that was fantastic. And moving on, our next presentation is we're going to hear from a couple of our community connectors. So, Lisa, I think you're up first, aren't you? And I think Sammy's joining us too.
Yeah. Hi, can you hear me okay?
Yeah.
Yeah, perfect. All right. So hi, everyone. So my name's Lisa Farrell, and I joined ELFT in September 2020 alongside 10 other community connectors recruited from City and Hackney's voluntary sector. It's a very new role, and much of what we hope to do with the role is still being explored and tested. So today I'll just briefly explain the purpose of the community connector role, as well as some of the ways that we've started working with service users over the last few months. Can I have the next slide, please? Thank you. So yeah, so as community connectors, we're embedded inside ELFT's mental health services in City and Hackney. And we're really working holistically with clients, giving them sort of the time and opportunity to explore any area of life that they feel might be impacting on their well-being. So you can see from that list, it could be, any area of life, from mental and physical health through to support networks, personal interests and hobbies, education and employment opportunities, or even really practical matters around kind of accommodation and finance. Next slide, please. you. So yeah, so as in a practical sense, so what we're doing is first of all kind of exploring and identifying areas of life that service users might like to strengthen or make changes in. And then we support service users to identify sort of relevant local resources. So that could be a range of different services, grassroots organisations, local activities, courses, groups or meetups that can support service users to connect into the community and reach any goals that they might have. And another really important part of what we do is also exploring any barriers that might prevent service users from accessing that support. So that could be financial barriers, so maybe someone's out of work and they can't afford public transport or to pay for groups or activities, any physical barriers they might have, sort of disability or any mobility requirements, technological barriers, so working with people who may be digitally excluded to make sure that they can access remote support. That's been really important at the moment, obviously with lockdown and COVID. And also emotional barriers. It might be that someone's very anxious about leaving the house or engaging with new people and activities. So we really try to support them across all areas of just finding things to do and organisations to link into, but also, feeling ready to engage as well. And like I said, it's a very new role, but some of the tools and approaches that we've been testing out over the last few months are sort of undertaking really person-centered and holistic assessments. So we're using a tool called Dialogue Plus, which invites service users to rate their level of satisfaction across different areas of life. And it also lets service users decide what to focus on and set goals around. We also offer quite a lot of flexibility in the length and intensity of support. So we recognise that people have, really varying levels of complexity in their circumstances, often multiple support needs. So we currently don't have a cap on sessions and we're working according to the client need. And the other thing to say is that we're taking what we're calling a helicopter approach. So by that, I mean that we're continuing to support clients sort of after the point of signposting or referral and making sure that they've been able to engage and connect in a meaningful way. So someone doesn't get discharged sort of as soon as they've been given information about a service. Can I have the next slide, please? Thank you. So one of the really important features of the connector role is that we're working within ELFT, but we remain employed by a range of voluntary sector organisations in City and Hackney. So you can see from the list that there's a really wide range of organisations being represented by the connectors, and we all have different specialisms in supporting the local community. And there are a number of reasons why this is really important to the connector role. Firstly, it means that we're joining the ELF teams with kind of specialist insight to the different communities and support needs of Hackney residents. And that's especially true for connectors who represent culturally specific organisations in the borough. Secondly, we have a pretty decent understanding already of local resources and the support available, and sometimes pre-existing relationships with those organisations and groups. So we're not starting from scratch. We already know what's going on a lot of the time. Thirdly, although it's been described as a new clinical role, it's really important to note that as voluntary sector employees, we're taking a distinct non-clinical approach to working with service users. And that can be really important sometimes for service users to know that we're able to be, a lot more holistic and flexible in our approach than is sometimes possible within other NHS services. And I'd say sort of the final important thing about, being a voluntary sector employee is that we're a direct line of communication between ELFT and our host organisations. So it means that we can really start to close the gap between statutory services and the voluntary sector, and that leads to all kinds of opportunities and cross-learning and collaboration opportunities as well. Can I have the next slide, please? Thank you. Yeah, another really important thing and feature of the connector role is that we're actually all allocated to specific neighbourhoods in Hackney. So this map shows how the neighbourhoods have been divided up, and we each support service users who are residents in our allocated neighbourhood. We do also have 3 community connectors who work across all of the neighbourhoods, and they offer culturally appropriate support to service users from the Afro-Caribbean, Turkish and Kurdish, and Orthodox Jewish communities. Next slide, please. Thank you. And the reason that this neighbourhood working is so important for us is that it means that we're able to develop an in-depth knowledge of both kind of the support needs, but also the strengths of the communities which are unique to our neighbourhoods. And it also means that we're able to develop a really detailed map of sort of hyper-local resources. And we're currently in the process of mapping these sort of neighbourhood assets, as we're calling them. So reaching out and starting to build relationships with a really wide range of local groups and organisations that exist in each neighbourhood. Next slide, please. Yeah, and sort of like I said, it's a very new role, so we're just kind of getting our feet under the table at the moment and starting to work with service users and test that out. But looking forward sort of into next year and beyond, some of the areas that we're really looking forward to exploring will be kind of thinking about how we can work really closely with local organisations and groups, you know, potentially upskilling them and supporting members of the community who may have mental health support needs, as well as providing support that's preventative in nature. We also want to begin exploring co-production, so working with ELFT service users to identify groups, workshops or services that would help to support mental health and wellbeing in the local community and specific neighbourhoods. And one of the ways that we would like to deliver this support is through peer support training, so working with the people participation team to create opportunities for ELFT service users to run groups and offer support in their local neighbourhoods. But one thing I'd say that is really, really important to all of this is that sort of both ELF facilitated or peer facilitated support is actually taking place in community spaces, and that we begin to move away from clinical settings and really start building sustainable support networks in each of our neighbourhoods. So yeah, that's it from me today, and I'm going to hand over to Samantha Francis, and she is a community connector who also runs a really grassroots organisation that supports the mental health of Hackney's Black community. She's going to talk a bit about her experience so far as a connector. So if you have any questions for me, do pop them in the chat and I'll do my best to answer afterwards.
Thanks, Lisa. Good morning, everyone. Glad to attend this event this morning. So as Lisa said, I'm Samantha Francis and I run Find a Balance. Find a Balance is a mental health grassroots organisation aimed at the BAME community, predominantly the African and Caribbean community. And we run a recovery programme of 24 weeks and we support individuals back into their mental health well-being, back into employment and sustainability. And the difference with our organisation is that it's more of a bespoke, holistic approach to recovery and support. At FAB, we don't believe in the one glove fits all approach. It's down to the individual. So when I was contacted to join the Hackney Community Connectors role, I was really excited because I realised that the NHS is looking at different and holistic ways of working, which is really, really needed. Now, I'm one of the Hackney Downs community connectors, and I've been in the role since August. And what I find is that it's at its really early stage. So we all come together at weekly meetings, bounce off each other. But what I find a difference as someone from the voluntary sector that runs their organisation theirself is that we have that control to actually make that change. So because we are the professionals that know more about the communities, we are the people that are on the ground, that are in touch with those communities and specialise in working in those communities. So we're able to bring our transferable skills from our own organisations into the role that we're actually doing. For instance, I'm working with a few patients who are from the Moroccan background, you know, that are isolated from everyone, other communities, etc. And the thing for them is that where is people from their community, you know, that they can bounce off and resonate with. So I'm able to go out there and source that and connect them in. You're in control of what you can actually do and bring to the table. Now, if you look at the ELF systems, one of the things that we've had to adapt to, as Lisa mentioned previously, is a diagnostic plus tool. And that's just assessing the individual, you know, where they are, what they see for their future, how are they feeling about goals, skills and aspirations. And I was discussing it with Lisa yesterday that sometimes when you go to do those type of assessments, the individual's just not ready to discuss things like that. They're not at a point where they want to talk about you know, those type of things. They're not ready. They've never had to. So we're in a position where we can break it up a bit and do some part in one session and then tell them we'll talk about another part in another session. So we've got like more flexibility in the way that we're working. And also when you're working with individuals, it's not just really about, you know, what they're struggling with as in their mental health illness. Life happens. So you've got like housing problems, you've got benefit problems, you've got, I've spoke to someone who's completely isolated from their family. They're the only person actually in this country. So there's such a wide scope of what you see and hear as a community connector. And it's about hearing what the individual wants and going out there and sourcing and finding that for them. And that's different, isn't it, when you're working with ELF? So we're in a position where we can sort of like shape the way we work with individuals to give them that, you know, great service. And I think it's really, really important because time's evolving, times is changing. I mean, look at the position we're in now. We've got COVID. We can hardly do face-to-face. We're working completely digitally or on the phone with patients. So things happen in life and you just can't have that one glove fits all approach. And this gives us the opportunity to move forward in a different way. And as Lisa was saying about co-production and, you know, having peer support is really important because no one knows a community like the people that are actually in that community. They're the ones that understand that community, and we're the ones that bridge the gap between ELFT and these communities and bring them together to work together. So, you know, it's something that at the moment I'm really enjoying. I'm looking really forward to seeing, you know, the impact in say 6 to 12 months and seeing the difference and just shaping and building the role as we really go along, to be honest. So yeah, that's all I've really got to give. I hope that's all right for everyone. Any questions, please put in the chat for me and I will answer. Thank you.
Thank you so much, Sammy and Lisa. There's loads of questions actually. What I'll suggest is that I'll read you a couple of the ones that are sort of coming up. There's people interested around the sort of training or professional background to community connectors and a little bit about how they differ from social prescribers. There's
okay.
Do you want to start that one?
Just to say,
Lisa.
No, I was just saying I'm just going through and answering a few of them in the chat, but if you want to take a few, Sammy, that's great. Don't mind.
Yeah. So we've had core training that Mind has, you know, put on for us, and we have a choice of have you done training or you haven't done the training. So we have things like managing difficult situations. We've got things like equality and diversity. So there's a whole, I can't remember all of them off my head now, but we do have access to like brilliant training to support us within our role. Some of us, because we've all got different experiences. So some of us have already done some training. Some of us have already done mental health first aid. So we don't need to repeat that again. So yeah, you get training to support you within your role, definitely, and good quality training as well.
Thanks both. And another one which has got a couple of thumbs up is around community connectors, how they plan to make the most of digital and technology opportunities that the pandemic has brought.
Oh, right. Yeah. Well, you see, everything's done online now. So I use a thing called Clinico for my meetings. So I have a video meeting with my patients if they want to. Some have opted out and just want telephone calls. But I think moving forward, we will have to create workshop around different communities online, whether we're using Teams or Zoom, because obviously everything's moved digitally. So we have to look at the long term of the role and, you know, shape it around working digitally, because without that now we wouldn't be able to do the role that we're doing. You know, as much as we love the face-to-face contact, because it's different, we all have to come together and create our peer support groups, our workshops digitally.
Brilliant, thanks. Should we take one more question? And I'll go for another one with some thumbs up. Well, there's one which is just around how people are referred and by whom. So something about that, the nuts and bolts of how this works on the ground, I think.
Yeah, sure. So there are a few different methods at the moment. The one thing to say is that not all community connectors are working inside blended teams at the moment. So the blended team pilots are being rolled out gradually across the different neighbourhoods. So community connectors who are in blended teams can be referred to by GPs or other health practitioners in those areas, and the referrals will be reviewed at kind of morning referral meetings, and then it will be decided whether or not a community connector is sort of best placed to be the first person to make contact. But for connectors who are working outside of blended teams, the referrals at the moment can only come through senior practitioners in EPC who are already holding clients on their caseload, or the recovery team. So usually it will be service users who are being seen as outpatients by community consultant psychiatrists. So at the moment we're being allocated sort of from referrals that are coming into EPC or recovery, but next year we're definitely going to be looking at how to open that up and be able to take referrals from sort of the wider community and other organisations as well.
Fantastic. Well, thank you both so much. That was so informative, and been clearly so many questions. I think people are really curious to find out more. So hope you're able to stick around and answer a couple of those in the chat.
Yeah, definitely.
Yes, definitely. Thank you all. Cheers. Thanks for listening.
So our next session we've got is one which is just as a Q&A. So I'm going to hand over to Imrana, Judith and Rhiannon to I think talk you through it. But a part of the background for this is when we've been having conversations with other sites across the country, there's a huge amount of interest from providers and commissioners about how best to work with their primary care colleagues. So we thought we'd set this up as a bit of an open space for discussion to help you think about how best you might do that and how that works well. Rhiannon, I think I'm handing over to you first, aren't I?
Yes, you are. Yeah, thanks.
So over to you, Rhiannon.
Thank you. Hi, everybody. I'm Rhiannon. I'm the clinical lead for mental health in City and Hackney CCG, and I'll be introducing and asking questions of Imrana and Judith. Imrana is the clinical lead in Newham and Judith is the clinical lead in Tower Hamlets. So in North East London, very interesting, diverse area. I'll tell you a little bit about City and Hackney before I move on to the other two to talk about primary care networks, neighbourhoods and transformation teams and how they all fit together. City and Hackney, we have 8 primary care networks and a very interesting difference between, say, the PCN, which encompasses the City of London, versus a PCN in North Hackney, which has a large ultra-Orthodox Jewish population and I think the greatest number of under 5s per 100,000 population in the UK. So as you can see from that, the PCNs have a lot in common. They're primary care networks. They are in an area, geographical area, but they also have diverse populations within them, and hopefully the transformation work will start to look at a sort of population health within each PCN and address the particular needs. So that's our little description in Hackney, City and Hackney. We have 8 PCNs. I'll just pass over to Imrana to describe Newham and how the PCNs work there. Hopefully she's around.
So I'm slightly concerned that Imrana doesn't appear to be on the call.
Oh, never mind, we can move to Judith. Judith will be there.
I think she'll be joining us. She came to the test call earlier, so we should be all right. I think we're a bit ahead of schedule, so she may be joining now. So,
okay.
Judith.
Hello, I'm Judith Little-Johns. I'm a GP in Tower Hamlets, and I am the clinical lead for mental health for Tower Hamlets ECG. So in Tower Hamlets, we've actually had networks for over 10 years. So our networks are quite mature, which is a real advantage to us in this kind of working. If you think of GP practices as your nuclear family, and then they see each other every day, they know each other really well. And then you have the PCNs, which are marriages of 4 to 5 practices. And they're your extended family. So it's a merger of a number of different sort of nuclear families together. And there are 8 PCNs in Tower Hamlets, and they are paired up into localities. And each CMHT covers a locality. So each CMHT has 2 PCNs to relate to. And then we also have a GP federation, which is quite mature as well, called the GP Care Group. And they cover all of the practices and all of the PCNs in Tower Hamlets as well. And in case Newham isn't, in case Imrana hasn't managed to come in yet.
I think she might be here now, Judith. I think.
Now. Can you hear her?
I can hear her. I can hear her. Great. Imrana, do you want to chip in about Newham?
Yeah, hi. Apologies again for the IT issues. It worked perfectly about half an hour ago, so I'm not sure what happened. I think I just caught the tail end of what Judith was saying, but I think you've said it all. In terms of PCNs in Newham, I think different to Tower Hamlets. In Newham, it's a very new structure, and I guess if we think back to when we started with our transformation just over a year ago, in Newham there weren't any PCNs, and the PCNs hadn't been agreed. So it was a very interesting scenario at that point, because people outside of general practice didn't know what PCNs were, and then those who were within primary care and general practice were still trying to work out how the PCNs will develop. But I think we're in a better place now that the PCNs have been established for the last year and a half. And as I think Judith has already explained, that there's a huge variety within the PCNs. Some only have kind of 3 practices, some have up to 7, and the variation in between that is quite wide as well.
Thank you. And leading on from that, I think, there's a huge amount of transformation work going on, obviously, over our boroughs. But exactly as you point out, huge transformation in terms of setting up PCNs. So just thinking about our role as CCG clinical leads, how's it going in your areas? What's it like? What would you have done differently? How is it anyway?
So, I mean, I think definitely it's been a journey. If we kind of go back to perhaps at the beginning of the transformation, when where maybe a lot of the people who are listening are at the point now, I think it's just, I'm not sure if you just mentioned this earlier, but it's just worth kind of noting that the clinical directors of the PCNs have multiple competing priorities. And although mental health is our world, it's often for this clinical directors, it's a very small part of what they have to deal with, and unfortunately, mental health isn't always and often isn't the top priority. So I think just being aware of that when you are starting the conversations is very important. Like, for example, now. GPs have been tasked with delivering COVID vaccines to the population. So if you turn up and say, I want to talk about this thing that we want to do with CMHT, it just doesn't, although it's massive and amazing work, but it's not, you're not going to be able to grab their attention. So I think, talking specifically about kind of the role of the CCG mental health lead, I think so definitely within your systems to be able to engage with your mental health lead. But often, I don't know about Judith and Rhiannon, but in the beginning, I really felt I had to kind of be an advocate, a champion of the transformation, because nobody. And I think that again, the challenge is that we weren't going to people with a clear, definite plan or a frame or kind of exactly what things would look like. It was we were asking people to follow us on a journey and trust us. And that's harder than if you say, look, we've got this model and we're going to have 6 mental health nurses in your PCN, and this is where they're going to sit and this is what it's going to look like. But again, that's the antonym of what we're trying to do in this transformation. So that has been challenging.
Thanks, that's really helpful. I'll come back to that issue of trust actually, because I think it's absolutely vital, and it's where we have strengths, I think. Judith, do you want to add to what Imran has said?
Yes, I think the other thing is that you do need to invest in leadership if you want to have any change. So we, every PCN has its clinical director, but we've also got mental health clinical leads for each PCN to be looking specifically at this, to kind of create time and space to do that. And they've been a mixed bunch, because some of them are very well known. They've been sort of leaders in Tower Hamlets before, and they know exactly what to do as a clinical lead. Other clinical leads, this is their first clinical lead post, and so they're really needing a little bit more sort of mentoring and sort of bringing along and learning what clinical leadership is. And it's great because we need to bring on new clinical leads, so this is a great opportunity. But a lot of it is about relationship. You mentioned trust, Rhiannon. It's about knowing your colleagues, knowing your practice, knowing your network, the culture, the relationships. You know, who's the drunk uncle that you want to avoid? Who's the person that you want to, you know, who's the key player that you know you need to talk to get anything done? And so it's knowing the people, really. It's all about building relationships.
Yeah, I totally agree. I think the same in City and Hackney. I mean, the value of knowing your colleagues and being able to talk primary care talk, because as Imran says, I mean, mental health is our world, and you know, I can say personally I'm completely obsessed with it now, but it does give that breadth where you can reach people who perhaps don't regard mental health as their primary interest in general practice, but they might be interested in physical health, in which case, well, okay, we've got the physical health agenda, or they might be interested in frequent attenders at A&E, or medically unexplained symptoms, or long COVID, or all of these things where mental health is integral to what's going on. And I think because we have that broad sense as GPs of the physical, the mental, etc., I think, yeah, and the trust of our colleagues, I think that is about embedding clinical leadership. And exactly as you say, Judith, bringing up those GPs within PCNs who've not had that role for a long time, who feel anxious, who don't know anything about what they're supposed to be doing as leaders. So I think, yeah, it's a really good point. Imrana, did you want to add anything, or did Judith want to add anything, or if there's any Q&A, Jamie, if you want to come in and interrupt us, because we'll just chat on forever.
Well, there's a couple of questions in there. Do you want me to read out some of the ones that have come in?
Yeah.
There's one around, have any PCNs contributed existing primary care roles to the new blended community teams, or do all primary care staff sit outside of the blended teams?
I mean, Imrana, do you want to take that one? Or I'm happy to, but do you want to answer that?
Yeah, I mean, that's a very good question. And also it kind of, it makes me think about when we talk about the transformation. Again, Jamie and I have been sitting, working with the national, on the national learning set for the transformation sites, and I've heard this word a lot within the transformation and outside of the transformation, but I think for it to be kind of effective and meaningful, people have to feel that it's their transformation, and different organizations and different professions. So I think if we are able you know, all our colleagues to feel that this is because it's happening in PCNs, it will affect everything. It will affect, you know, every patient that we see and the way that we see them. That if everyone feels that they are part of the transformation. But kind of getting to the particular question, I think. So again, PCNs are very different places. So some have appointed particular roles and some haven't. I think perhaps the question is about the mental health practitioner, which is one of the new roles which are coming in within the PCNs. So I know locally that those posts have not come in yet. So that it's a good point at this point to have those discussions, because I don't think there's a right or wrong, but if things are done in silos and not knowing and complementing each other, then that's a great loss.
I think, I think certainly in City and Hackney, we would be thinking that a blended team is much wider than the ELFT blended team. So we have social prescribers, we have Well Family, we have other voluntary sector organisations, we have Tavistock and Portman primary care input. You know, we would be regarding everybody to be in a blended team, and that might be a very Hackney typical classic jigsaw approach, but that's how we would see it. So yeah.
And I'd like to just add, this also reveals some of the challenge that you have when you're trying to coordinate a project across a large area, when every PCN has autonomy. So, I mean, there are a number of roles that every PCN has to have, like social prescribers and pharmacists. But there are other roles like physios, OTs. You know, my network has OTs, or it's the only network that I'm aware of that does. So if every network has a different range of staff, how do you create a common way of doing things, a common pathway, when you don't even have the same staff within the various different PCNs?
Yeah, it's a real challenge, I think.
There's a question around, I think you've sort of touched on it, but what would you suggest in supporting proactive involvement in pioneers? And it also says RCDs in PCNs.
So I could
proactive involvement. I'm not too sure I kind of get the question, actually. Perhaps I'm being a bit dim, sorry. Judith and Imrana, do you? I mean, I think it comes back to leadership and getting in there and saying this is important. And I think, as always, you know, finding the people, exactly as Judith said earlier, finding the people who will say, yes, we'll do it. And yes, we're interested, and yes, we want to change stuff, and, you know, keying in with the active people. But I might not be answering the question. Perhaps the other two can answer it better.
I think you also have to look at what level you want to do change. So if you're wanting a fast sort of plan, do, act, you know, kind of assess cycle, you want to do it quite small. So often starting with one practice within a PCN. So our pioneer PCN has started with one practice first, and then it went to a second practice, and now it's trying to get it to all of the practices in the PCN, and then it's sort of working on the next sort of PCN next door. And you start off really, really small, because that's how you can get engagement. You can just about get all the GPs in one practice to work together, but getting the GPs in 4 different practices to work together is going to be quite hard. So you start off small, prove that it works. That gives confidence that you can take it forward and people are prepared to try it. I've just seen a question that Richard has put up around sort of training for PCN clinical leads as well. And I think one of the things that Rhiannon, Imran and I have really been quite passionate about is trying to sort of mentor and bring on new clinical leads. So although when Geraldine Strathdeed did her sort of amazing training that Rhiannon and I were both on many years ago now, which was at the very beginning of CCGs, we're now in a position where we are trying to mentor and bring on and sort of train and come alongside people. So rather than having an external training program, which is probably quite expensive to run, it's us handing on the baton, really.
And I would say, in that keys into people's interests. So rather than have a sort of standard mental health training program, yes, I mean, you need a little bit of training, but also key into people's interests. So just an example, one PCN in City and Hackney really wants to focus on transition, so 18 to 25s. Right, so we're looking at what that means. And in terms of mental health, it can mean a lot, but they want to do the whole thing. They want to do physical health and mental health. And so the PCN director is very keen on that. Okay, let's get some training in you know, let's talk to different groups. Again, it's both going with what keenness there is in the community, and there is a huge amount, and also having that sort of space to get people feeling more skilled, I suppose. Imrana, did you want to say anything?
Yeah, no, I agree with a lot of those points. Going back to the first question about engagement within PCNs, again, I mean, I do feel that we're kind of in a good position at the moment within our own transformation, particularly in Newham, where, for example, we have a kind of a transformation action group, we call it, where it's the Pioneer PCN team who comes together on a 2-weekly basis, and we have about 60 people who attend that, and that's every 2 weeks. So I think to get to that phase, I think what Judith says is really important. And again, although we're trying to move forward with this transformation, I think it's useful to have an understanding of the history and particularly about the practices. And as I mentioned before, I think initially we were doing a lot of kind of advocating for the and championing for the transformation. But once you get those people who are keen on board and they start to be involved in the change, and other people start to see the change, I thought, and if you use those voices, so for example, as Judith said, when we used one of the practices first within the Pioneer PCN started to make those changes, and then the staff within the practice, they feel the sweetness of what's being delivered. Then use that voice. You know, you can step back at that point and then use their voice to forward it. And particularly after the first few months, when we had a few. Particularly one clinical director who had seen that actually this is benefiting our patients, then you can use those voices and as you know, as with every profession, you know, people trust their own. So if another GP or a CD is saying this is working in our practice, then that's a big sell. And just very quickly on the second point, which I think is really important, because regarding the building the skill set of the clinical leads within the PCN. So again, we had been talking about this recently, that I think it's easy to assume that when you're appointing somebody to a kind of a clinical leadership role, like a GP clinical lead, that they'll just be able to run with it. But again, exactly as Judith has described, the variety of GPs that you get involved is also quite different. Like, for example, within our transformation, we have a GP who's very experienced in diabetes, like a national speaker in diabetes, but has little experience in mental health. And conversely, we have somebody who's only been a GP for about a year. So I think just having that kind of space and time for, rather than training, it's more kind of mentoring and coaching is really important. And rather than thinking that if for those who are, you know, a step behind us in coming into and designing their models, then having that kind of time space allocated and a way of doing that from the beginning would be, I would say, very beneficial.
Yeah, I definitely think so.
Fab. I think we've got time for one more question. And there's one that I think Richard's answered, but just to get your thoughts too. Are you looking to break down barriers between primary and secondary care to create an overall community mental health offer?
Oh, well, I think that we could answer 1, 2, 3, yes, would be our answer for all that. I mean, absolutely. You know, what do we like as generalists? We like things to happen. We like things to happen quickly for our patients. We like services with no thresholds. We like services that are flexible. You know, absolutely break down the barriers between primary and secondary care. Yeah. Imran and Judith.
Well, I think there's one thing that I've noticed. When we first started this, it was a pre-COVID. All of our meetings were face-to-face, and I was cycling up to the borough, which was getting me really fit. But now, because of COVID, you know, everything's on Teams, which means that actually it's much easier to have a meeting. So we now have a Teams meeting, you know, in the Pioneer network. They have a Teams meeting every day set up, and you know, if you have a patient to discuss, then you pop into the meeting, and you know, you can do that for 15 minutes. Well, you can't do that if you have to kind of walk around to the CMHT. So actually, it's really interesting doing this transformation in the middle of a pandemic. It has helped us think in a more digital way. It's not helping my fitness levels, but it does mean that we pop in and out of meetings. It's more efficient, and because of that, we are communicating more. But you do need the tech to do that. And so one of the challenges has been, you know, a practice level is the right level to do a new innovation and trial it out. But if you're trying to get laptops and headsets and webcams, which we didn't have any of sort of in February, you need the larger level, the kind of the GP Federation kind of layer, or the sort of or the ELFT sort of trust layer, to start producing some of the IT and the kit that you need to make this happen. So you do need to be working at all the different things to be able to get that working well.
Just a point to add as well is I think the answer was in the question in itself. Yes, you know, breaking down those barriers, that's our dream. Because to be honest, for the patient, it doesn't matter if they're classed as primary or secondary care. They need the right care at the right time. So I think that's you know, in the PCN space, we are seeing that, as Judith has described. The only kind of caveat, perhaps I could say, or a word of caution, is that although we want to break down the barrier between primary care and secondary care, there still needs to be some kind of like a graded way of who sees like what specialities and which clinicians see which patients, because if you don't do it in a way where that's quite graded, and in some ways clear, then you can firstly have inefficiencies, and also people aren't seeing the people that the patients aren't seeing who they need to see. But the way I kind of describe that is, rather than having those thresholds and barriers which are diagnosis dependent, it is about complexity. So I think, you know, clearly those who are less complex don't need to go down the full route of what the PCN transformation can offer, whereas certainly there are patients who definitely wouldn't have who definitely don't meet, you know, current secondary care thresholds. But there's a lot that we're doing within our transformation space that is helpful for them.
No, I think of that concept now of a package of care, where mental health therapy might be one bit of it, social prescribing, yoga classes, going cycling, cooking might be another bit of it. A whole package, you know, employment, exactly as all the previous speakers have said. So yeah, I think it's a fantastic change in that sense. Yeah.
Thank you, folks. That's a lovely note to end on. Yeah, thanks so much. That was fantastic. And I'll just ask that there are lots more questions. So if you're able to cast your eyes to the chat box and answer any of them, that would be fab, because there's lots of kind of curiosity and lots of questions from different people. Our final 30 minutes before we go for a little lunch break, we're going to hear from a couple of our pathways. So first of all, I'm going to hand over to Murto and Mina, who are representing this the complex emotional needs pathway development. Over to you, Murto. I think you're first, are you?
Hi. Sorry, I thought the disordered eating guys will go first. I mean, we're happy to, but I think they go first.
Oh, sorry. I think maybe I've got the slides the wrong way around then. Brian and Catherine, are you around?
Yes, we are. Well, hi.
Should we jump ahead to
yeah, we're here.
Is that okay? Okay, so we'll go for the disordered eating pathway first. Sorry, my fault.
No problem. Thanks, Jamie. So we are sharing obviously this time with the complex emotional needs pathway as well. So we don't have a lot of time. So I'm going to do my best to keep it really succinct, and so Catherine and Laura and Ella can really think about the finer details of what's going on. So if you could put up the next slide, Jamie, please. So just to quickly say, we're naming it disordered eating because we really want to think about support for people whose relationship with food, eating and body image is problematic for them, or for those who care about them for that matter. A lot of this presentation is going to be on the kind of restriction end of the spectrum. So if we're thinking about this disordered eating as a spectrum from kind of overeating and obesity on one end to undereating and restriction on the other end, I guess the majority of this presentation is going to be focused on the restriction end. The main reason for that is that there's already existing services in mental health services for eating disorders. And so we kind of wanted to work where the light is, as they say, and kind of expand on that. But our vision is really have an all-encompassing provision for people on either end or all of the bandwidth. So this is where we're starting from, or we started from. For eating disorders in East London Foundation Trust, the outpatient, inpatient services and community services are located in St Anne's Hospital. And so ELFT service users would have to go to there and for the moderate and severe end of the spectrum. And there was an existing service in Tower Hamlets that was linked to the IAP service, but was commissioned by the CCG, and that provided kind of the mild to moderate end of the spectrum for eating disorders. So this is where we started from. As you can see, there's a big disparity across the 3 London boroughs in terms of how many referrals go to St Anne's. Each are referred to St Anne's each year. So there's, as you can see below, 188 in Hackney, say, compared to 45 in Newham. So that was one of the kind of main flags that we were looking at. Next slide, please. So this was the kind of a complex pathway. I'm not going to spend too much time on this, but there was huge amounts of difficulties, transitions, complexity, multiple assessments, service users kind of, loads of opportunities for service users to get lost in the system, and really kind of a somewhat disconnected pathway. That was here at the start. So next slide, please. And loads of little diagrams. So this is what's the emerging pathway, and this is the kind of context. We'll speak more about the early intervention and prevention bit in a second. But just to say that along with the Tower Hamlets IAP service, Newham are following suit. So they will be supporting people with mild eating disorders in the coming months. It's January 2021 is the earmarked date, but that's to be confirmed. And Hackney also are following suit and are collaborating with us in this as well. So, but that's April 2021. But again, these have to be confirmed as well. The whole pathway meets in the pathways meeting, and we're ironing out the details with regards to this. But I'm going to hand over to Catherine to speak a little bit about the early intervention prevention, specifically about service users and experts by experience and involvement in that, and also Laura and Ella after that. So over to you, Catherine.
Hi. Hi there. So my name's Catherine Lazenby. I'm a people participation worker for disordered eating. So just to start off, just to say that we're really wanting to think about not necessarily creating a sort of discrete service as such, but really a provision to improve people's experience of eating disorder through outreach and education, through carer support, and through community support. Next slide, please. So here's just something here about co-production. We really want co-production to be absolutely at the heart of this work that we are doing. And by that, we mean doing with rather than doing to. So doing with, it's really about having that equal and reciprocal partnership with people, and ensuring that they are engaged throughout the whole process. So right from design, consultation, and even in delivery as well. So we will be thinking a lot about training and education, and we want people with lived experience to be actively involved with that. So again, just trying to counter that idea that we are always doing to people, that we are trying to fix people who are just the passive recipients of care. That's something we're really wanting to counter. Next slide, please. Actually, no, sorry, go back and keep it on that other slide for now. So just to tell you a little bit about myself, first of all. So I'm an expert by experience, and I've actually been involved with the Community Mental Health Transformation Programme for about a year. I originally became involved with the programme just as an expert by experience, attending all kinds of different meetings and just using my voice and experience to help guide the direction of travel, particularly for this work on disordered eating. So drawing on my experiences as someone who's had an eating disorder for their whole adult life and who's been using services in East London and also Barnet-in-Enfield and Haringey, where St Anne's Hospital is based. So in those initial stages, I was attending meetings with clinicians and with all kinds of people involved in helping to flesh out ideas around what sort of work we should be doing to improve the experiences of people with eating disorders. I'm also a tutor at the City and Hackney Recovery College. So initially, my involvement was a case of attending meetings, and then I started to support Brian in running some interviews with other service users. So this was a really important part of that kind of co-production aspect of the work. We wanted to meet with people with lived experience to really talk to them about what their experiences of accessing services had been like, and particularly what had been helpful or unhelpful about their very first contact with services, particularly because we're interested in this idea of prevention and what we can do to improve early intervention. So what sorts of things had become barriers to accessing care, things like long waiting times, poor referrals, poor communication, lack of education and understanding around eating disorders, and other damaging experiences such as being turned away for care because people were deemed not to be unwell enough, which is something that's really, really common within people's experiences of eating disorders, and unfortunately, runs the risk of actually increasing people's severity. So we spoke to people who had been identified by St Anne's Hospital, by people participation, by the Child and Adolescent Eating Disorder Service, and word of mouth. Next slide, please. So these interviews were really helpful in terms of getting to know people closely and to really sort of speaking in depth about their experiences. And that led on to a series of focus groups that we ran with service users. Again, to just kind of dig in a little bit more into a bit more detail about people's experiences and what their thoughts were around how best we could address some of these issues. So we started off this focus group in kind of quite an interesting way by first imagining that we were aiming to design the very worst provision possible. And this was a really great way of getting people to kind of vent their experiences and to share things that had happened that had been unhelpful. And so some of the themes that came up were, the very worst provision would be something that had a lack of information around eating disorders, that was very formulaic, something that was very exclusive, that only treated eating disorders without allowing people flexibility to be treated by other mental health teams. A service or provision that was weight focused and didn't look at the person as a whole, that failed to recognise diversity, and again was very much about doing to and not working with. Next slide, please. So having talked about this idea of imagining how would we design the very worst provision, from that we then kind of extrapolated and thought creatively with these focus groups about what would the best provision look like, what might it involve, what kind of values would it embody. So we've got things here like seeing the person, not the disorder. Providing warmth, compassion and trust in the way that you work with people. It would involve outreach to schools, it would involve peer support, it would be flexible and fluid, accessible, visible, bespoke and person-centred. Those are just some of the kind of key themes that came up in these focus groups. Next slide, please. And so from these themes, from these in-depth discussions that we had with service users across a number of different focus groups, which I should say were led by myself in collaboration with the assistants in community psychology, who by this point, this was sort of mid-lockdown, first lockdown, by this point they had been recruited into their posts. So from all of that information, we were able to kind of collate it together and identify these ideas. An ethos for the provision, a vision and a value. So what do we want it to be? What do we want it to have? And what do we want it to provide? And this absolutely came out of these conversations with people with lived experience. I'm just going to pick out a few. So a key one here under ethos is that it should be person-centered and holistic. So really getting away from that idea that we're just seeing people as statistics or pieces of data. So they are more than just their weight, they're more than their symptoms, and that recovery therefore involves all kinds of different interventions and facets. It's not just necessarily about changing behavior per se, but actually improving quality of life. Also about it being less clinically focused, and again it's that kind of holistic approach. People said that they wanted to feel listened to, valued, respected, understood, and they are more than their weight and appearance. Under vision, people talked about wanting access to peer support and wanting that flexibility, again, as I mentioned earlier, so that they could be seen under different mental health teams. This is a really big problem. A lot of people experience that when they've got multiple diagnoses, often teams will say, well, we'll only treat this, we won't treat your other problems until they're sorted out first, and people just don't know where to get the support they need. And then finally, under value, what do we want it to provide? A couple of key points. A lot around increasing information, understanding and training. So people talked about not being given enough information about their own disorders to understand the problems they're struggling with. Similarly for carers. And again, a kind of strong identification of perhaps a lack of understanding among primary care about eating disorders, which I think really impacts on people's ability to get the access to the care they need. And sometimes it means that they are then waiting a long time for referral to specialist services because there isn't the confidence at the early stages among primary care to discuss those problems. And access for all, and ensuring that we are providing access for a whole diversity of a population, really thinking about the cultural diversity within East London, and also acknowledging the fact that eating disorders affect people of all ages, backgrounds, genders, ethnicities. So this information has been absolutely fundamental in really guiding the direction of the work that the disordered eating pathway has taken. And from this, we have extrapolated a number of different work streams, which Laura and Ella will come on to in a little bit. Next slide, please. So as I mentioned, I started off as an expert by experience consultant, and then in October I took up the post of a people participation worker, which has just enabled me to sort of formalise the work I do even more, and it's been a really exciting development for myself as well. So I've just kind of jotted down some objectives there. I mean, these really resonate a lot with what Becky was saying earlier about the general objectives of people participation. It's really about ensuring that service users and carers are actively involved in influencing the direction of work. So I'm hoping as well to ensure that I am helping the psychologists to kind of co-develop their work streams, as well as bringing other people with lived experience into the work. Next slide, please. This is just a little reminder to myself to mention one piece of work that I guess I'm particularly proud of, which was to develop a 3-hour training session for the assistant psychologists, providing them with an introduction to eating disorders, with input from Brian as well. This for me actually was a really proud moment just for myself. It's something that I've dreamed of for many years, was actually to be able to draw on my lived experience to help educate others. So delivering this training was really important and powerful for me. We talked about things like describing the spectrum of disordered eating, different types of disordered eating, and also really speaking quite personally about the barriers to support that people can face, the barriers to recovery, as well as exploring really practical strategies for helping to explore the functionality of an eating disorder, looking beyond the behaviours to the distress that drives it underneath. Now, this training I delivered to 18 assistants in community psychology, and we will be using this now as a basis for future training that we're hoping to roll out for GPs, enhanced primary care services, and in other settings as well. I'm going to hand over now to Laura and Ella, who will tell you a little bit more about the direction that we are heading in as a team and future work streams.
Hi everyone, my name's Laura Keys and I'm one of the assistants in community psychology in Newham on the disordered eating pathway. So as Catherine has already described, these early interviews and focus groups with experts by experience, we used to gain feedback on what people wanted our pathway to provide, and we use this feedback along with interactions with our staff to develop our theory of change that we've illustrated using a driver diagram, with our primary aim on the left, which we are now hoping to achieve by summer 2021, the primary drivers in the middle, which are effectively our streams, and the sub-projects on the right. We then split into small groups, each focusing on different streams, all of which are being co-produced and co-developed with experts by experience and people participation workers. Next slide, please. So the first 3 streams relate to direct service user support. Experts by experience felt it was really important that we have a digital presence and to also provide psychoeducation. Given the aims of the transformation project, these streams also allow us to increase accessibility across all 3 boroughs to provide support for those that are already within the pathway or will already be in the pathway, as well as those that are not. And obviously at the moment, in terms of physical access, given the restrictions with COVID, this is also really important to be able to allow people to access things that aren't face to face. And we're currently in the early stages of development for these streams. Then the Severe and Enduring Eating Disorders project is being run by Catherine with the aim of designing and developing community-based peer support at St Anne's Hospital for people with severe and enduring eating disorders, which will directly involve service users in the development of this. We also sort of hope as a result as well that this will help us to develop a working relationship with St Anne's and to hopefully allow us to include their service users in the development of our project too, obviously in the spirit of co-production. So next slide, please, and I'll hand over to Ella.
Hi there, I'm also an assistant in community psychology on the disordered eating pathway. So to follow on from Laura, in addition to those streams, we're also working on raising awareness and increasing people's knowledge within the community regarding disordered eating. So this includes increasing professional awareness. This has been something requested not only by service users, but by staff themselves. So by educating our staff, we hope to increase people's knowledge and their confidence as well in supporting those experiencing disordered eating. So we are co-developing this training and are piloting it in Tower Hamlets and City and Hackney EPC in January 2021. And then with the feedback we receive, we will then hopefully implement this training across ELFT services. But in addition to that, we're also providing carer support. So the impact of having a supportive and understanding carer can be huge for people, but it's also crucial that carers feel equipped and supported too. So we'll be running awareness trainings sessions for carers in order to increase understanding and provide people as well with skills to enable them to feel confident supporting the people that they care for. So we've arranged a focus group on the 8th of December with people in all the boroughs to identify what is most important for them to learn about. Next slide, please. So education. So as we're focusing on early intervention, we felt it was incredibly important that we work with young people. So we're aware of the varying needs between the schools and people in higher education, and as a result, we split them up. So for primary and secondary schools, we are assisting the Children and Young People's Eating Disorder Service in their project. So we're helping to develop materials for PSHE lessons in primary and secondary schools, and we're initially piloting this in schools in East London with the hope of being implemented wider in the future. And then with higher education, we've been liaising with the University of East London and are provisionally going to be developing and delivering support in January 2021 to students there. And then after gaining feedback from the pilot, we again hope to be implementing this to other universities and colleges. Next slide, please. So as obviously we've gone through this process, we've kind of come across different issues or different kind of learning experiences, and we've been able to reflect on those. So obviously this transformation work is an ongoing development, and it's an ongoing development for everyone. Therefore, it's been important for us to understand what other provisions are going forward and what other provisions are being developed within East London, and therefore where we sit. So it's caused us to kind of be quite flexible and adapt. We've had to adapt our approach basically. In terms of issues we've come across, so we've recognised there's a lack of evidence base for obesity. We think it's incredibly important that it's included as a topic in all the training we do to educate people on the different presentations of disordered eating. So it's something we're just mindful of and hopefully we'll be working on. In regards to co-production, it's obviously crucial that we have experts by experience and the wonderful work of people participation as well to be involved at every step. But we're also mindful of effectively using people's time. So prioritising the meetings that we invite them to, so that we're not kind of exhausting that resource. But also in terms of diversity, so we need to ensure our work is catering to a diverse range of people and not just the kind of stereotype of young white females. So to do this, obviously, we are working on an ongoing basis with the BME access psychologists and hope to be doing more work on that as well. So that, for example, when we're looking at balanced diets, ensuring that we're not looking at a kind of white-centric diet, but we're also aware of different ethnicities and cultures. I think I'm handing over to Brian now. Thank you.
Thanks very much, folks. I'm just going to keep it really short about the future. I guess the obviously we want to liaise closely with St. Anne's and IOCT and create, provisions around and between services located in the PCNs. We really want to emphasise direct service user support and have robust offerings for them based on NICE guidelines, and also training across the system is essential. The digital presence also needs to be one of the fundamental things we're going to develop in the new year, because I think people a lot of the time search for information and it can be a minefield or a kind of wiring out there. So it's important to give people as much information as quickly as possible. And the last slide, please. Next slide, please. Yeah, and so I guess this is how we see it. Lunch. I just want to go for lunch now. But this is how we kind of see it. I suppose future end-to-end pathway, where the green is where the PCNs lie. I suppose so we're going to have prevention and early intervention, transition support maybe for people, and specialist services and primary care services are going to be kind of embedded within this in terms of mental health. So this is kind of a future ideal that we're working to. Apologies for running over, and I'll hand over to Murto in the complex emotional needs stream. Thank you.
Hi all, thank you very much for this. So complex emotional needs. So basically one of the main things to say is that we are doing things slightly different across the trust. We are developing slightly different pathways in the 3 boroughs that are part of the transformation program. That's Tower Hamlets, City and Hackney, and Newham. But there are some common themes. So we have a very short period of time today, so it's impossible to go through everything. But one of the things that we want to highlight is about some of the maybe controversies and challenges about the actual terms that we use, specifically with this subgroup, and because we think that it is quite important, the language that we use. And then we will say a little bit about the work that we've done in terms of focus groups, where we have followed the same focus group sort of plan that was described by the disordered eating colleagues, and then just a little bit of an overview of where things are, what we have learned from the work in the different boroughs. So complex emotional needs, so this is the term that we are using in ELFT to describe the complex mental health difficulties associated with a diagnosis of personality disorder, which is how this subgroup is described in most of the literature. This is not a medical diagnosis. It is a broad term that includes people who have certain difficulties, and that's around emotional distress, self-harming, substance misuse, relational difficulties. And we are mindful that we want to include people who may have different diagnoses, but may have some of those characteristics and their life is affected. So I'll pass on to Mina.
Hi everyone, my name is Mina and I am a service user. I have DPD, so I'm an expert by experience. So I'm just going to kind of go through a few things about the sort of the feedback that we got from service users about this term, complex emotional needs. They found that in terms of the focus on personality disorders, it kind of gives it like negative connotations, and I think that there's a lot to be said about, you know, sort of the terminology
that's used for mental health terms just in general, but especially for personality disorders, because it suggests there's something inherently wrong with you. And I think that these things are overused outside of that as well. But I think also we've got to address the stigma that's attached to you know, complex emotional needs and personality disorders, especially across Black and ethnic minority communities and other marginalized groups, because they face other barriers. We all face different barriers, and therefore mental health may not be prioritized. And I think that's really, really important to note. I also think it's about the fact that CEN is something you have to kind of identify for yourself. You have to decide for yourself if it fits for you, because it's not a formal diagnosis, and therefore it's not something. It's quite a subjective label that not everyone feels like they can qualify for, or that they agree with. A lot of people I know wouldn't agree with the term personality disorder because it has those negative connotations. There was a bit of concern as well about the discussion of specific behaviors. So Mate went over a few of these, like self-harm, suicidal ideation, that kind of thing, and also things like excessive sexual behaviors, substance abuse, and these things can be a bit triggering for some people. It can also be just uncomfortable or not very sensitive for certain people in terms of like religious audiences and so on. So that's something that we have to keep in mind as well. And because we want to really catch the people who fell between the cracks of the system, I think it's really, really important to keep this term as broad and fluid as possible, rather than make it narrow and restrictive. And on that note, we want to make sure that we explain these limitations to any service users that we may apply it to, because we want to make sure that our transformation project is informed by the experiences of the service users at every stage. I'll hand it back to Myrte.
Thanks, Mina. So some of the things that we have found so far is that we know that the current models see demand outstripping the resources in psychology. There are complex cases that are being referred and bouncing around different services. There are a lot of people with those characteristics who are excluded from our current treatments, like people who are in crisis, homeless, substance misuse can exclude people. Non-white British service users are underrepresented in specialist psychological therapies, like, for example, personality disorder services. Whereas at the same time, EUPD presentations are overrepresented in secondary care psychological therapies. We found that PDs are generally underdiagnosed compared to the national estimates, and that's coming from primary care databases. And we also know that, I mean, we found from audits that we've done that at least 80% of people with this presentation have a history of psychological trauma. Next slide, please. So part of our three-part data review, we spoke to staff and service users, and these are some of the main points. So the pathway needs to be, any new pathway needs to be flexible and easy to access, continuity with crisis services and step-down support. There is a lot about staff training that needs to be empathic. I think some of this was definitely echoed in the disordered eating pathway. Diversity training needs to be quite important. There was a lot about matching with the service user and the people treating them. The help offered to be skills focused and empowering rather than illness focused, and interventions to be co-produced and facilitated. And people don't want long waiting lists, multiple assessments in flexible services, and unempathic staff over-focused on risk. And Mina will talk us through some more details of the findings from the focus groups.
Thanks, Myrte. So in terms of the focus groups, we did a similar, like Myrte said, about the similar framework, and we found that there were certain things that came up, like accessibility, compatibility in terms of therapists to patients, making sure that there was, you know, a good cultural fit. And that kind of ties into the diversity issues that we found kept coming up. And it's really a reminder, I think, for all healthcare professionals that healthcare does not exist in a vacuum. It's something that is informed by social, political contexts all the time, and it's not something that can be ignored, because a diagnosis is often affected either consciously or unconsciously by things like race, religion, perceived sexuality, and so on. So I think that's something that's really, really important to keep in mind. And I think a great way to sort of hammer this point home is to do so through training delivered by service users with lived experience. I think that could be super helpful in terms of providing the staff with much needed training for things like diversity, so then they can provide a more compassionate service. And one thing as well that came up was about the usage of notes, because we found that a lot of people kind of had to repeat and re-traumatize themselves in telling their story, especially in the specifics of self-harm, attempted suicide, and other quite triggering things that they had to retell because, you know, for some reason it wasn't on their file, or because the person who was referring them didn't really see or didn't look over them before. So I think that's something that's really, really important to keep in mind, because these things can be very traumatic. And I think one of the most the best sort of theme that came out of this was about the concern for staff well-being. You know, it was saying that the shortcomings in the service could have been linked to the therapist's own struggles in their mental health. And so it's really, really important that we keep in mind that if healthcare professionals have their own issues, that can come across in the service that they provide, and therefore it's really, really important for them to look after themselves, so then you are able to look after us. Back to Mato, I think.
Thank you, Mina. So yeah, just one. I'll go through this very quickly, and then I'll pass over to Mina again for the final point. I know we only have 1 minute, so just to say that basically we have been trialing things differently in different PCNs, in different local teams, but some of the findings so far have been quite positive in terms of trying to integrate secondary and primary care. There is much more communication, and the relationships are becoming stronger. It seems that GPs may, you know, feel more supported, and there is a quicker response, especially in relation to complex cases. We are seeing a lot of benefits from service user involvement, and we still have quite a long way to go. So over to Mina for the last slide. Thank you.
So thanks, Meta. So in terms of the overlaps that we found in our findings with disordered eating, we found that, you know, people tended to have to get worse before they could get access to care. That was something that sort of overlapped, and so did the need for staff training on these things, especially in terms of diversity, as well as the limitations of diagnoses, because you know, as they were saying with disordered eating, it is a case of, you know, sometimes often patients are reduced to their diagnosis. So I'm just seen as a person with BPD rather than a person in my own right. So I think that's really, really important to keep in mind, that we can pool resources and be more efficient in how we you know, deliver these projects, especially when there are people with dual diagnoses, i.e. having an eating disorder as well as a BPD diagnosis. And the final thing I'll say to kind of finish up is that it's really, really important, again, to reiterate that service user involvement is crucial at every stage of this transformation project in order to make it successful. Thanks very much.
Thank you so much, folks. That was fantastic and just so rich. And you know, draw your eyes to the Q&A, where there's lots of kind of appreciation and conversation going on. We've run ever so slightly over, but I'm proposing that we still aim to come back for 12:30. I know that that's a very short lunch break, and Brian saw the sandwich. He's probably very hungry. But hoping that you're happy that we try and push on. There's just some excellent stuff to come back to after lunch, so keen that we don't lose any time there. So let's aim to come back for 12:30 and have a lovely break. We'll speak to you shortly. Hi everybody. So I think we're just about to resume, and just before we go into the afternoon's presentations, I thought I'd just remind people of the plan for the afternoon. So coming up shortly, we'll be hearing from the Hackney Marshes and Clissold Park neighbourhood teams about the work they've been doing. We're then going to have a slot with our Chief Medical Officer and Director of Social Work about some of the changes or some of the implications, I suppose, about this transformation work for specific professional roles. And then we're going to be hearing a presentation around trauma-informed care. We have a brief bit of time at the end of the day for any sort of final questions as well. So thanks for people that are giving us questions in the chat box. We'll keep an eye on that and keep on trying to pick those up. And yeah, I'll hand over to the Hackney team. Over to you.
Hi, I'm Nicola Gardner. I'm the Neighbourhoods Director for City and Hackney. And I'm here actually with all of our team, and I'll introduce them shortly. We're going to talk to you about the blended teams in Hackney Marshes and Clissold Park. Our starting point for the transformation work was really understanding what mattered to our local service users and residents. So last year we held lots of focus groups, one-to-one interviews and partnership events across the city and Hackney to find out what people wanted. And what they said was that it was all about the wider social factors that impacted on their mental health and their well-being, things like housing, employment, benefits, and I guess social connections, loneliness and friendships. So it was all about relationships. And that's where we decided to start with building our blended team over the summer first and foremost. So we started pulling that team together from across ELFT, from the voluntary sector. You met some of our community connectors earlier this morning, from our primary care colleagues and wider agencies like Turning Point for substance misuse and Riverside for housing. And I think it's better if the team tell you all about what they've been up to, how we've been trying to move from that kind of web of complexity and all the different social factors into a web of support. So I'm going to introduce you to Peter and Priscilla, who are our consultants in the neighbourhoods, to Duncan, who is our community connector, to Moira McAllister, who's one of the GPs in Clissold Park, and to Daniel Malenga, who's one of our nurse practitioners leading the team in Hackney Marshes. So I'm going to hand over now to Peter McRae.
Hi there. Hi, my name is Peter McRae. I'm a consultant psychiatrist in Hackney, and I cover one of the first PCN, Hackney Marshes, that went live with our kind of new approach. So I'm just going to lay out some of the practicalities of it, and then people will expand on the experience of it. So when we went live, the main things that changed is that all non-urgent referrals were diverted from wherever they were previously headed through to the blended team. And on a practical level, that meant that the blended team is having kind of daily meetings where they review all of those non-urgent referrals, and also weekly meetings where a kind of broader group of professionals are brought together to review them, and a monthly meeting for complex case discussion. And I think, although other people will talk about the ethos more, I think it feels different. You know, it feels like we're passing things through a lens of social connectedness and trying to filter kind of the opportunities for that aspect of a changing culture, in addition to whatever the original intention of that referral is that we were looking at. And so now we're at the stage of those processes are up and running, and our challenges now are about clarifying some of the processes and things that we've interrupted, that we've got in the way of what people were intending to ask for, such as like feedback from wards and liaison with the wards about what their expectations might be at discharge. Also kind of moving some resources from our more traditional CMHT models to support the blended team as we start to scale up and do more. And then also kind of supporting service users who've been with some of our more traditional teams to move across into the blended team, understand the offer, and feel prepared to know what they're going to get and be confident that they've got the support that they need within this blended team approach. So that's a really kind of quick run through of kind of some of the practical things that we're doing. I think Priscilla, who's our lead for the transformation, is probably hanging around on one of the thumbnails at the moment to take over.
Hi, yes, thank you. Hi, thanks very much, Peter. Yes, I'm Priscilla. I'm also one of the consultant psychiatrists in Hackney, and our pioneer team at Clissold Park went live this month, following on from Hackney Marshes. And we chose Clissold Park because that was where, it seems a very long time ago now, but we started our triple aim quality improvement almost 2 years ago, where we had focus groups that Nicola mentioned, but also we compiled lots of qualitative and quantitative data about what really mattered to our patients, what mattered to our service users. As Nicola said, the wider social determinants such as housing, employment, but more importantly, the thing that came out was social connection, lack of social connection and isolation. And of course, this is way before coronavirus. So we started up initiatives like the Bike Club, joining with different voluntary sector organisations. Not all of the organisations focused on mental health. Some were out to provide social connection and to attend to isolation with residents of Hackney, not necessarily those with mental health problems. So we worked on that framework, and already we had a lot of integration happening. And when we rolled out our Clissold Pioneer, with our daily meetings of referrals that Peter mentioned, and GP involvement, we also involved the recovery team. So we're all working together in a blended team, and it feels very different because really what's happening is we're having a much more detailed discussion of referrals that come in, and thinking very carefully and sensibly about what would be best, what could we offer that would be something different and new to our service users. We started so looking at some patients who would benefit from a more trauma-informed assessment, so some long assessment times just with myself, and then also myself with a GP, to look at trauma history. And this is thought to be very relevant because a lot of our patients who we find are stuck and not being able to move on, often there's a trauma history, personality disorder factors, with the trauma history, looking at a trauma-informed formulation in order to move forward. And that's been a real something that I think will really change the way we look. We've had a lot of GP involvement. We have daily meetings, but a weekly meeting where the GPs will be invited, and this will be a really quick feedback and good feedback loop about how referrals are, how the blended team is working in primary care. And we've also started transition clinics. So of course, a lot of the recovery team are really taking part in our new blended team. We're using certain pathways that the recovery team, the old CMHT team, and there's a lot of people are very excited and interested in this new way of working. We will run some transition clinics between moving people from the traditional recovery team, where they're seen once every 6 months by a doctor, to something that's much more holistic, with our community connectors, with our EPC workers, and with our voluntary agency colleagues. I'm going to hand over to Daniel now. Thank you.
Hello, my name is Daniel. I'm
the senior practitioner for the Hackney Marshes blended team. Mine is going to be just a brief update or feedback regarding staff, how staff finding the transformation so far, and what I can say is so far so good. It's been very interesting and very exciting to be part of this new transformation, where every day, every morning, you're part of this this number of professionals that are coming together to discuss referrals and you know, making plans on a daily basis, and with a focus not only on the diagnosis, but focusing on those things that surround the patient, and amongst ourselves, like the community connectors coming up with, you know, what they feel they can do for that patient, whilst considering other practical issues that we can offer to the patient. So far, one of the support workers in my team has found this very helpful, and he says it's a good learning experience for him, because other than what has happened before, where he's been allocated patients with where he's not been fully involved in terms of the reason for that referral. Now with the blended team, we are all sitting there discussing and expanding or exploring what we need to provide for that patient. So him as a support worker is finding that very, very exciting. So having this weekly meeting as well, where you discuss other, you know, complex cases that you may not have explored to the conclusion on a daily meeting. On Monday, you bring those cases to this meeting where we have a lot more professionals, and you discuss this. So all I can say is it's something that is going on so well, and it's good that as we go along, obviously having started this pilot on the 5th of October, we've also been looking at things that are working, you know, that are working well and that are working not working so well, and then we think and brainstorm on how best we can you know, change and work towards this, achieving you know, a more quality, you know, care provision for the residents, the provision that won't just focus on their diagnosis, but that which will focus on the social determinants of health, because we are so committed to doing that, so that instead of looking at a patient with a diagnosis, we're looking at the patient who has got all these other issues that surround them. So we focus on those and try to work with those, to work on those with the patient. So it's our hope that that is going to work so well. And so far, feedback I've got from one of our patients who I was talking to about this issue, she was so positive with it and she couldn't wait to be part of this. So yeah, I think that's all. That's the only feedback I can give at the moment.
Hi, hand over to Moira.
Hi there, my name is Moira McAllister and I'm a GP at Somerford Grove Practice, which is part of Clissold Park PCN. I just wanted to share with you my experience of this work. I've really appreciated this new way of working, the warmth of the work and the emphasis on trauma-informed care, as so many of our patients have suffered so much trauma and need to learn how to survive their trauma, and as professionals, that's what we're trying to help and support them with. As GPs, we sometimes and often feel left with our patients who might not fit into the system. We get frustrated with our rejected referrals, and we never discharge patients who we always have those patients with us along, and we stay with them along their journey. And we know that medication and even psychotherapy are not always the answer for patients, and actually that social factors and connections are really important for people. I thought I'd give you a really quick flavour of how this work has helped me as a GP. Tell you what's happened in the last 2 weeks with me. I'd say one of the great things is the accessibility. And now that we're so good at working with teams, it's been really easy. So one day I popped into a daily meeting via Teams, so that was for about 10 minutes. I'd made a referral, but I was able, by popping into the daily meeting, to make my referral more colourful, and I was able to relay my concerns about the patient, which probably don't come out in a GP referral very well. So being able to actually speak to people in the mental health team and tell them what I was worried about was really invaluable for me. On another day, I attended the weekly meeting. And I was there for about 30 minutes, and I knew I was attending that ahead of time with some other professionals, and we discussed the discharge of a patient, a very complex patient who was leaving secondary care and coming into the community. This handover was one of several handovers we've had, but this one was quite practical. So it was about who's talking to the patient on what day. What do we do if there's a crisis? Who do we contact? What support can we get as GPs? You know, who are the contacts and how do we stay in touch? So that was a really useful exercise for me, something that I've not had access to that kind of discussion before. And the third thing that happened in the last 2 weeks was I attended the longer monthly blended teams meeting. So this is a longer meeting that we've said described already. It lasts about an hour and a half. Me and a fellow GP attended together, and between us we were able to discuss 3 patients in quite a lot of depth. I'm so impressed by the quality of thought around the complexity for these patients, and for me it's really amazing to have psychotherapists, people like Duncan, who's going to speak after me. We had colleagues from CAMS and elderly care all together in a reflective space to think about patients who we really worry about as GPs. And I had spoken to the patients, asked for their consent, obviously, and asked them what really mattered to them. So really at the heart of this model, and what I've appreciated the most, are the gentle, compassionate, thoughtful discussions that have been happening between professionals. And for me, it's a really different and exciting way of working. And I really value it, and I've been grateful to be part of it. I'm going to hand over now to Duncan Dandy, who's our community connector, who's been great to work with as well.
Thank you, Mario. Thank you for that. So yeah, my name's Duncan. I'm the community connector for the Clissold Park neighbourhood within Hackney. My colleagues Lisa and Sami gave a great presentation and explanation of the connector role this morning, so I'll do my best not to repeat what they've already said. So the same as the other connectors, I'm employed through a voluntary organisation, which in this case is Peter Bedford Housing Association. In terms of the bare bones of the role, there are obvious difficulties as most sort of classes have moved online, community centres have closed, and sort of meeting residents face to face for that initial contact is more difficult, although it's not impossible. But this has made us more resourceful, and we're building up an extensive knowledge of online resources and classes, so that's really good. So part of what I've been doing as well is reaching out into the community, joining things like the neighbourhood conversations, which include like council members, community centres, local faith groups, and that's helped me to sort of build up a knowledge of the sort of hyper-local organisations and resources, and I'm also getting involved in sort of discussions on new community build spaces, which is really good when we're looking at sort of peer-led support groups and things like that. And also getting involved with organisations like Health Watch Hackney, who can sort of help with people participation for designing a leaflet for the residents to explain the blended teams. In terms of the people who I've been supporting so far, I mean, it's still fairly early days for myself and the other connectors, but in terms of my caseload, there's a lot of people who are under 35, people struggling with their employment, or people who have fallen out of work due to their mental health, quite a lot of people who are at university in their teens and their early 20s, and that's obviously like a difficult period in life as it is, but especially with the pandemic. So in these cases, I might be helping to link them into support that already exists within their university or their employer. There's been a few other cases where I'm helping people who are making the move from organisations such as St Mungo's into their own housing. So in those cases, I'm linking in with key workers and making sure that that difficult transition is as smooth as it can be. And sort of within the blended team, in the morning meetings, sometimes it's assigned to me to make that initial contact and assessment instead of that traditionally being the senior practitioner, if it's deemed that it's most appropriate for me. So that's really refreshing, and that's nice. And so it might be that I sort of go and get some more information, and then I'll bring that back to the weekly meetings for the team to see how we can best proceed with their support. So yeah, as sort of Moira said and everyone else has said, like having those daily, weekly, monthly discussions with everybody there who's really supportive and knowledgeable just makes everything so much easier, and I feel sort of excited for the other neighbourhoods to make that transition as well. So yeah, thank you. I'll hand you back to Nicola.
Thank you. I just thought I'd finish up our session with some feedback that we got only last week from one of our psychologists who's working with a service user. And the service user had quite a lot of experience of mental health services, had been in and out of them for a number of years, tried different types of therapies and interventions, and nothing was quite working, and his circumstances during the pandemic had considerably worsened, and he'd been rejected from a number of different services and had been referred into the blended team. And if we looked at the thresholds of the services that we could have potentially sent him onto, none of those would have worked. So the blended team worked with this service user, and I think in fact it might even be Duncan who's been working with him, looking at some of the things that he's interested in, some of the kind of strengths that he has around music and sound engineering, and looking for particular activities and groups that will help support him. And we also have other professionals in the team who are now supporting him with some brief interventions. And he has a referral to a local group that helps support men who are feeling suicidal, because what happened was, in having a conversation with this service user, rather than just sticking to looking at forms, the psychologist discovered that he was actually really quite suicidal and starting to make some plans, and that would have never come through on the traditional forms and in the traditional referral route. So we've now got the whole team wrapped around him, working with him, and his feedback last week was that just having somebody talk to him and ask him what mattered and what's important in his life, he's now feeling 100% better and is engaging with these different forms of support. And the very last line on the feedback we got was, "This is really worth it." So I just wanted to say thank you to all the team who've helped make this work for our service users and local residents as well. So that's everything from Hackney, Marshes and Clissold Park. Thank you.
Thank you so much, folks. That was wonderful, and yeah, there's several questions. I hope you're able to stick around for a few minutes in the chat box and answer some. There's lots of people really interested in the sort of practicalities about how you come together and who comes together and the populations, and so yeah, thanks for the presentation. It'd be great if you could pick up some of those. But we must move on to our next presentation, which is about the impacts of this this transformation work has on certain professionals. So I'll introduce David and Jill. I'm not sure who I'm handing over to first.
Hi Jamie, it's me. Thanks, Jamie. Jill is actually here with me. So first of all, just to introduce ourselves, my name's David Bridle, and I'm the Medical Director for our London Mental Health Services in ELFT. And I'll hand over to Jill.
Hi everybody, can you see me? Jill Williams, Director of Social Work for ELFT. Thanks for inviting us in. So I'm going to start and we're going to just share some thoughts with you about what this means for professional roles. Obviously I'll be talking about social workers and David will be talking about psychiatrists. And I hope you can hear us through the masks. I'll speak loudly and as clearly as I can. So for social work, the transformation, I think, potentially demands the most change, but also presents the greatest opportunities. And that's because there's been a steadily growing narrative over a number of years, certainly from our colleagues in senior roles in social care, but also from social workers themselves, suggesting that mental health social work has lost its way a bit and needs a reset. That social workers have moved into a generic role which has divorced them from their core professional training and strengths, and that this disadvantages the people with whom they work, as their understanding of and access to social care resources has not been fully understood and maximised. So an example of that would be the Care Act, which has been around since 2014. And we're still getting quite strong messages, I think, from social care that we're not fully utilising the Care Act, that for most of the directorates in ELFT, there are delegated responsibilities and Care Act assessments and accessing Care Act social care packages should really be part of the core work that we're now all doing in our teams, and certainly moving into the primary care space. This is a great opportunity to really strengthen that work, focus on it and ensure that our social workers understand Care Act assessments and how to implement them. So this is a positive step for social work, I think. It builds on a new vision for mental health social work, which is a document recently produced by Health Education England, and it attempts to address, what should social workers in mental health be doing? How are we different from nurses and OTs and other health professionals, and how do we work alongside them but also deliver our own and develop our core professional strengths and move away from a generic model? So this vision sees social workers delivering new models of social care provision, which are holistic and place-based, and draw on the individual own strengths, but also recognise their connections with the community around them and seeks to mobilise that community to refocus on the social determinants of health, supporting education and employment, meaningful relationships, and assisting people to access housing and benefits. This is an opportunity, as I've said, to build expertise and assessments under the Care Act and offer packages of support which enable recovery and promote independence, and of course are co-produced. So the role of the social worker in the primary care space will be to offer high quality early triage and assessment, which both signpost to community resources where appropriate, hopefully, building on a prevention agenda, but also social workers should be able to provide comprehensive Care Act assessments which assist access to support packages which are co-produced and meet people's aspirations and support recovery. So that's the hope. I think there are challenges and risks. And listening to the news yesterday about the economic forecasts, it would be foolish not to recognise that as a major challenge. At the same time that mental health services are receiving this, fantastic investment and working on the transformation, local authorities are facing some of their most challenging financial situations for decades. And, you know, Croydon has galvanised and scared everybody, I think. So I think we have to recognise that as a real threat. Pay freeze for social care staff will also certainly impact recruitment and retention and the ability of social care to continue to employ and attract staff, particularly in London. We also have to persuade our directors of adult social care to work with us in the transformation space, and that this provides real opportunities for them and their citizens. And that's, I mean, many of them, I think, do recognise that and have signed up to that, but it's very hard, I think, for them to focus on anything at the moment but balancing their books and managing the financial challenge. The last thing I'll mention as well is, I think, you know, we can't underestimate that also this will require new ways of working for our social care workforce in mental health. Not all of them. Many of the more recently qualified, the think ahead social workers will very much have been trained in this model. But for people like me, who have been working in generic mental health roles for many, many years, this will undoubtedly require some retraining, some rethinking and some upskilling, and a very solid senior support and supervision structure. So my hope is, and my belief is, that social workers will embrace this, will be very enthusiastic about it, but I think we need to be realistic about the scale of the challenge. So I'll stop there and hand over to David.
Thanks, Jill. So I mean, there's a lot I could say about my reflection on the transformation, partly in terms of this transformation project and how it's gone and what that's meant for medics, but also in a much more general sense. And just before I get into that, I guess, you know, it's worth me explaining. I've got a clinical role, which is in primary care liaison psychiatry, and then I've got a leadership role, which is in the medical director role. And in that medical director role, I've obviously linked into this program from the beginning, from when we started to put together the proposals and from that point really through everything. And I just wanted to reflect, first of all, that actually it's been an incredible piece of work that's been going on. And I think you've all had a real taste of that today in terms of some of the people who you've seen, the presentations they've given, and kind of the flavour they've given about how people are thinking about things and how people are approaching things, because that's what's going to matter. We can draw structures together, we can do whatever we like, but actually it's kind of the hearts and minds and the way in which we all work together. It was mentioned earlier, I think it was Imrana who highlighted relationships as a really key thing, and it's absolutely right. The relationship building that's been going on and the working together and the co-producing, which has been really powerfully explained today, I think has been really wonderful to see. And of course we're sitting here with masks on and nobody's mentioned COVID very much today, but actually I think it's also really striking that despite the massive impact of COVID over this year and the potential for that to really just kind of throw a spanner in the works with everything that we were trying to do in terms of trying to move stuff forward, it's a real testament to everybody's kind of commitment to this and desire to see this move forward, that actually we've had things continue. Yes, there's been some disruption, but actually on the whole there's been kind of an ongoing effort to use the opportunities here and to continue to craft what this looks like and learn from this, draw in stuff that's helpful and so on. So, and I think that's been really well represented today, and I think that's a sign of the really amazing people we've got around us. We've got fantastic GPs, you've seen some wonderful examples of them today. We've got some fantastic service users who've been really involved in helping us to shape and develop things and are definitely part and parcel of everything as we go along. We've got wonderful clinicians, and you've heard from some of them as well. So I guess when I'm talking about when we talk about transformation, some of it depends on the ingredients you've got. And I think some of the ingredients we've got, you've seen a bit of that, but some of the other ingredients we've had to start from in terms of if we're thinking about transformation is that here in ELFT, we've had kind of services that have focused into primary care already. So we had existing services, the enhanced primary care service that was mentioned, and primary care liaison psychiatrists, like the role that I've done clinically. And so that's enabled us to have, a close working relationship between mental health and GPs that really was a good building block in terms of relationship building, in terms of kind of thinking about people together in that space and thinking quite holistically about people in that space, but not necessarily the wider systems of things and the wider co-production of all of that that has kind of been enabled through this transformation. I think one of the other things we've had is a real kind of commitment to co-production as far as possible in the trust, which has meant that kind of for people working in our trust, for the psychiatrists working in our trust, the idea of co-producing and really trying to kind of live that co-production in a true way, truly doing things with people, is something that doesn't feel alien or strange in terms of embarking on this. And so I think there's various bits of the ingredients that have been there for us, which are really helpful as the starting point for kind of where we've gone in terms of this transformation. And I guess the other thing that I really want to highlight is that obviously, and I'm going to talk about psychiatrists, but obviously psychiatrists can be a range of views out there. Different people have different views and what have you. And I think that will be the same for any profession or any group of people that we speak to about transformation, about the direction of travel and so on. But as I say, we've been on this direction of travel for a while with some of those building blocks starting to kind of happen there. And I really do think that we've seen a lot of positive engagement from our psychiatrists in the trust with this direction of travel. We've got some fantastic advocates who really talk really strongly and powerfully about the good experiences that they've had in terms of working in the space and where it's going and why this is important and how this matters for the future. So I guess that links in partly to kind of how you view what the models are and what matters. And so from my perspective, and it's shared by many people that I know and probably most of the psychiatrists that I know, a truly good model here and a truly good medical model. And so the medical model can be kind of dished a little bit in terms of people can narrowly interpret what that means. But actually a truly good medical model is about being holistic. It isn't about purely focusing on some biological aspect. It's much wider than that. It's the biological aspect, it's the psychological aspects, it's the social aspects, it's the spiritual aspects, it's the cultural aspects. It's really a good medical model is formulating an understanding of a person together with them to help figure out what would make a difference in all those different realms in order to move things forward and improve the situation for the person. And so if we have that in mind, as well as the kind of the ethos of focusing on being preventative and really empowering people that we're working with, then if you pull all of that together, all of the ambitions of this project are really aligned with what actually I think is good care anyway. And so it's really then a matter of just making sure that kind of we kind of find a way to operationalize some of that and make it as effective as possible. But actually it's already kind of aligned with what is good care. So it's not a world apart when we're talking about this transformation. It is embedding the systems that enable good care to happen and the right kind of thinking about people, with people, and identifying ways forward together. Within all of this, some aspects of the psychiatrist's role are simply going to be fairly similar in some regards. So there will be kind of individual assessments that will take place, formulations being developed together with people. And it's not about seeing absolutely everybody, because that's not going to be realistic. But it is making sure that people with the relevant complexity of needs who could benefit from seeing a psychiatrist and helping with some of that thinking and options for moving things forward get the opportunity for that. So we need to make sure that right to access high quality psychiatric assessment is available when it's needed or at the point of referral, if that's the right point of time. The psychiatrists obviously need to kind of also have an important role to play in the wider case discussions, the reflections that are going on. I think we've already heard a bit about that, so I won't go into that too much more, but also kind of, offering the relevant advice and, even if they're not personally working with individuals, they really also need to be contributing to some of the population level considerations. And some of that has been happening before now as well. There's some really good examples where together with kind of with the GPs, for example, and with others, we've kind of looked at some of the population level stuff and considered ways forward. And so everybody's brought their contributions to that. I think that psychiatrists also have a really important role in supporting and collaborating in the way in which they provide leadership in the system, so that really all of this does come together, that it all makes sense, and so that everybody is kind of connecting and thinking together, making sure that evidence-based kind of approaches are incorporated into practice and into thinking and so on. So I think that there's kind of some of that leadership role that's important to bring in the right kind of way, and as we've discussed, so on some level this is not a world apart from the kind of expectations that one should have of a psychiatrist, in my mind. It is kind of taking it into a different space and working in a different manner perhaps, but some of this is connecting right back to what is good principles of good medical care, good psychiatric assessment, but actually much more embedded in a wider system in terms of enabling some of that with the connection to the community, the connection to much more than perhaps we've been effectively connected into before. We've perhaps signposted more than been effectively connected into it. Having said all of that, so I'm really clearly very positive about it, and I think that would represent, as I say, most psychiatrists that I know, but there are concerns around, and I think it's worth us being mindful of the concerns, because we need to make sure that whatever we're doing does address those concerns as we go along. So one of those is that kind of there's obviously going to be a concern around the potential for, if we call it, threshold changes and self-referrals, and what this might mean, and whether that might be overwhelming. Would kind of managing demand become an impossible kind of task within some of these spaces? But in particular, I think that the concern with that is the potential risk for people who have really significant complex needs with severe mental illness, that doesn't get lost. And so we need to be actively guarding against inadvertently losing access for the people who most need it in whatever system we're kind of finally kind of adopting here. Another thing is that I think it's a challenge for us to ensure that from if, talking about the psychiatrist's role, it's a real challenge to make sure that the right people get the opportunity to see the psychiatrist, so that they've got that expert input when it's indicated. So how do we maintain this being a specialist role within this kind of space, and so that we kind of use it in the right way? And I think that was, again, Imrana referred to that a bit earlier in kind of what she was saying, so I definitely identify with that. I think there's something about managing identity. So the identity may feel very different in this kind of space than it's felt like in some more historical arrangements for services. So it's being in a primary care setting, in a wider network, but also being a specialist, being connected to the mental health services. It's all, there are various realms in terms of which that kind of identity needs to be kind of felt. It will probably be felt very differently as we go along. And so there's the potential for some tensions within that as well. I also think there's a realism that we need to be mindful about, that as much as we can help people as far as we can, of course, there will be some situations that are really difficult or even impossible for us to particularly solve as such. And you take examples of people without recourse to public funds and things like that. Some people in incredibly difficult situations, and despite the best intention and the best connections that we make across and so on, there will be some limitations in terms of what is possible, despite the very best intentions with all of that. Although obviously there is stuff we can do within some of those spaces. And then I think the other key thing is really just making sure that the experience of people moving between individuals, either within the blended teams or more widely, if they're kind of stepping into some of our other services of, early intervention or whatever it is, that feels seamless and is well connected. So there isn't any sense of kind of issues with kind of, barriers and stuff like that, that actually, and it was spoken about again earlier, that primary secondary interfaces, it doesn't feel like something that's a threshold issue or something like that, that we've got a seamless way for the experience of the individual who's been able to access the right stuff at the right time. I guess within all of this, I think there are things to do with training. that we need to be working on and within the transformed arrangements. So that might be more kind of things to do with, for example, specific skills. So if you think about things like population-based and preventative approaches, and perhaps something that hasn't been a big focus for psychiatrists previously, that starts to kind of take on more importance in terms of thinking in the space and being more effective in this space. But also things through to softer skills about kind of, you know, the manner of working in the right way with others in this kind of space. So there will be a range of things and kind of, you know, personal development aspects that will be important. And I think that recruitment's going to be an issue for everybody in every regard. It's a broad issue generally already, but I think it's just something for us to be mindful about as we go along. And then I guess the other thing that I want to say with that was that the whole transformation project has been done in a way that, as was described earlier, we didn't go in with, you know, everybody sitting down, drawing up what it will look like and boom, just implementing it. We've gone in with a very kind of iterative model to change and using quality improvement as kind of at the heart of it all. And obviously that's really intended to enable the creativity and kind of allow people to figure things out in the way they have been, as you've been hearing. But it also brings a lot of uncertainty. And so, you know, I think we're now starting to move to a point where really the kind of operational frameworks and clinical governance frameworks are under greater focus and more clarity and relevant job planning that links into that. And I guess in terms of then my reflection for that for the psychiatrist is that you know, some people love iterations and being creative, and others prefer the certainty of exactly what this should look like and stepping into a more certain kind of arrangement and role. And so you know, there's some people who bring strengths in terms of each of those, and so it's working with the right people in each of those spaces as we go along. So if I summarize very quickly, there are three main messages that I'd give out of all of that I've been saying. One is that I really think this is a positive step from a professional perspective. I think it builds on a direction of travel that we'd embarked upon, and it fits with the kind of holistic approach that epitomizes what I think high quality mental health care should look like. Secondly, I think there are still challenges about how to translate what are really well-intentioned goals of the transformation into an arrangement that doesn't lose focus on things inadvertently, like those with severe mental illness who might be catered for in a particular way at the moment, and that we don't lose touch with that and lose sight of that, and making sure that we get the right people getting the right input from a psychiatrist at the right time, so that the setup allows all of that to happen. And then thirdly, just like any other profession, I think making changes to services and iterating and creating new approaches and reshaping one's identity within the service setup is going to be easier and more natural to some individuals and to some psychiatrists than to others. And so it's thinking about how to support people with that. So those are probably my overarching reflections, although there's a lot more that I'm sure could be said about any of those. Yeah.
Thank you both so much. So there are a couple of questions. There's one which is got a few thumbs up next to it. I think it's probably for David, about should psychiatrists really be the lead professionals? Is this still relevant? Any thoughts on that?
So I don't know, we haven't defined something as a lead professional as such here, I don't think. I think we've all been bringing our bits to kind of think about it. So if I look at, for example, the disordered eating pathway, we've been part of that work with Catherine and Brian and others, and it's been a really interesting space to be in. Catherine has brought loads. She's been really, really powerful and effective in terms of helping to shape exactly what that looks like and develop it. Brian is a psychologist by background rather than a psychiatrist, and in that particular space that was the right person for kind of bringing his skills, his knowledge and his expertise in terms of the disordered eating pathway. So he is the lead on that pathway, for example. So we've got, you know, if I was to describe, I see both of them as having really powerfully influenced and shaped that. Yet we've also had Rhiannon and Judith and Imran and myself in there, so GPs and psychiatrists and so on. So we've had professionals like myself as a psychiatrist, GPs and what have you, but actually the leadership there has really, I think, been brought by Brian and Catherine in particular. So I'm not sure that it is it's defined up quite so clearly as that, I guess. But I do think there's an important role for psychiatrists to bring leadership. I think it should be part and parcel of what psychiatrists bring. I think psychiatrists have got a significant training. They know a lot of the evidence base in terms of helping to think about that and bring that to help shape things and make sure that we incorporate that into the thinking. And I do think that psychiatrists provide an excellent opportunity for the right kind of leadership to be brought there. But that does not mean it's all about psychiatrists providing the leadership. It does depend on the space we're in and so on. And so it's not as clear cut as that, I don't think.
Just to say as well, we haven't really touched on the approved clinician role, which is something we've not developed hugely across East London, and this might be an opportunity to think again about that and whether that's something we want to put some energy and focus on. I completely agree with David that this is much more about fitting around a person what works for them rather than having very clearly defined hierarchical pathways. It's about what is best for the person that we're seeing.
Fantastic, thanks both. I don't know if you're able to stick around for a few minutes in case there's any more questions that pop up into the chat box. But thank you. We'll move on to our final presentation of the day. So I think I'm handing over to Sinead first, and we're going to hear a presentation around trauma-informed care. Sinead or Marion, who am I?
Oh, it's me, it's Sinead.
Hi, Sinead.
Okay, hi everyone. Yeah, my name is Sinead McQuillan. Can you hear me? It says that I'm muted.
We can hear you.
Oh, lovely. Okay, I'll ignore that then. So my name is Sinead McQuillan and I am the people participation worker for complex emotional needs. And a part of my role means that I will be involved in the trauma-informed care. I don't really want to call it a pathway because trauma-informed care goes across every discipline and every person and is not about one particular group of people. So I'm going to talk a little bit now about trauma. Obviously, this is a trigger warning for anyone. We will be talking about trauma, just so you're aware. And later on, I will pass over to Dr. Marion Bates. So she is the trauma lead in Newham, and she will be explaining a little bit more about how that's going to work and how it is currently working in the community transformation programme. Please can I have the next slide? Can I have the next slide? Oh, sorry. Thank you. So, and the next slide again. So, yeah, what is trauma? So, I'm sure many people already have a good idea of what trauma is, but lots of people associate it with big events, such as being in a war or in a huge domestic situation, rape. Really big events, but sometimes trauma is more complex than that, and it's events that can cause fear or pain or provoke loss, exclude us from others, relationships which inflict harm or others, absence of care, neglect, or witnessing any of the above. Next slide, please. So these are what are known as adverse childhood experiences. As you can see from the diagram there on the left of the screen, it talks about abuse, about emotional abuse, physical abuse and sexual abuse, neglect emotionally and physically as well, and other factors maybe within or around the home, such as domestic violence, substance abuse or misuse, mental illness, parental separation or divorce, and parents who are in prison or perhaps in mental health hospitals or otherwise not in the family home. So people with 6 or plus adverse childhood experiences can die 20 years earlier than those who have none at all. And 1 in 8 of the population have more than 4 of these. If we could move on to the next slide, please. So people who have experienced trauma are 15 times more likely to commit suicide than those who have not. And you can see some of the other statistics around the side there. So issues with alcoholism, with addiction, injecting drugs, having to take antidepressant medication, job problems, etc. So while we're just talking about this, I just wanted to share my own experience, because I am an expert by experience as well. So when I was growing up, there were a series of things that happened to me that spanned from, well, when I was still in the womb, when my mum and dad were quite violent with each other, emotionally, that is. And then all the way through until my early adolescence, which involves some bullying and things like that. And these things alone probably are quite easy to, well, not easy to overcome, but are easier than if there are lots of things together. So we're not talking about one specific event, but complex trauma that affects someone over a length of time and in different ways. Next slide, please. So I'm going to pass over to Marion now, and she's going to explain the 3 E's of trauma and the 4 R's as well, and then how that works in the community transformation programme.
Marion, I think you are muted.
Sorry.
That's what.
It's getting to the end today. I'm Marion Bates, clinical psychologist, and I work in the secondary care psychological services, but I'm also the lead for complex trauma across Newham. And with my 2 counterparts, one in Tower Hamlets, Murto Sakapulu, who you met earlier, and Elena Alexandru from Hackney, we are developing trauma-informed care, so training and consultation and general indoctrination of the workforce across the transformation project and also across secondary care services. So Sinead's just really helpfully outlined what the 3 E's of trauma kind of represent, really thinking about events, experiences and the effects on people. So just because you might not have experienced an event as traumatizing, other people might have. So we're really thinking about helping people to get alongside service users and help them, so that we can really understand the impact that trauma has had. Could we go back to the second slide, please? Oh, where's it gone? There it is, thank you. So this is a really helpful summary of what trauma-informed care is. So trauma-informed care recognises that traumatic experiences terrify, overwhelm and violate the individual. And it is a commitment not to repeat these experiences in whatever way possible, and in whatever way possible to restore a sense of safety, power and worth. So trauma-informed care has been developed over many years with service users from the ground up. It's very much a sort of social activism based approach where all the way along it's involved people participation. So that's exciting. Could we please go back to the next slide where I have another acronym? Here we go. So the 4 R's is really what we're trying to teach people, and in the transformation what we want to do is to see trauma-informed care as a kind of set of lenses that we look at everything we do through. So this is from the very smallest interactions that we have with people right through to the you know, much broader sort of organisational level approaches. So in terms of the 4 R's, we're looking at really realising the impact that trauma has on people. And we're recognising the need to acknowledge that. So in terms of the training that we're doing with staff, we're rolling out sort of videos of us talking about trauma and really trying to get people to apply that to their work. So thinking about individual teams, how you can realise and recognise the impact of trauma on individuals that we're working with. So that's really thinking about tiny things like bullying, which can have a huge impact, as Sinead says. We're recognising that people might have difficulty trusting us. So the way that a service user might present might appear to be aggressive. It's probably reflecting some history of trauma and a sense of fear. We're also thinking very much about our staff, and this is something that you mentioned, David, I think, that really thinking about the impact that the trauma of the work that we do has on people, so the vicarious trauma that our staff and that we are all witness to, and that causes trauma in ourselves. So thinking particularly about 2020 and the sort of ongoing COVID situation, which I think it has been very traumatizing and is, you know, causing burnout amongst staff. So we're also thinking about how we respond to trauma. So that's number 4. How do we respond in trauma-informed ways? So number 3, how can we resist the urge to re-traumatize people? So we really want to remember the vast history of how mental health services have affected people right from the asylum era, how we have treated people, and we really want to resist the re-traumatization of people. So this has been particularly in inpatient units, and I think those of us that have worked there have seen people being re-traumatized by some of the practices that they've had to enact as part of their job. Next slide, please. Aren't these slides beautiful? Sinead has taken a very boring ELFT presentation and made them look amazing. So next slide, thinking about trauma-informed care in the community mental health and community health transformation. So what we're really thinking is working alongside community projects. We can't go and do all of this stuff, and actually this is mainly what people have been doing all along. You know, this is what we went into working in caring for people for. We went in it to be compassionate, to get alongside people and to help them. Yeah. So we want to use adapted versions of existing training developed with service users to strengthen the existing services that are already happening. We want to think about how adverse experiences and trauma have created you know, the difficulties that people come to us with, so the inequalities that people are experiencing. We want to make sure that things are appropriate to the individual and reflective of their own culture, and that we're not going to re-traumatise people in East London in our hugely diverse population. Next slide, please. So the aim of our project really is to embed the training and kind of supervision and consultation in a trauma-informed way. So thinking about psychosocial formulations, increasing collaborative working within the structures that are already existing, and using third sector organisations and other statutory services. So the aim is really to embed knowledge so that the services can keep working in this way, so that we have different parts of the community working to ensure that we don't lose any learning. Because I think a lot of the funding for the transformation approach is temporary, and we really want to make sure that we can embed learning in the communities that we're working alongside. So the existing trauma lead psychologists I mentioned before, we're going to be involved, and we're also in the process of recruiting some more psychologists, people participation leads and peer supporters in order to carry out this work. And we're also going to be using the existing assistants in clinical psychology and other staff in order to roll this kind of trauma lens out. Next slide, please. Thank you. So one of the things that we're looking at is thinking about improving everybody's ability to understand and approach others in a way that we're going to help to reduce disadvantage and difference. So I'm not mentioning mental illness here very much, but the way that we look at mental illness is that it is the outcome of a history of trauma and adverse experiences. So that's how we really look at our trauma-informed formulations. We're looking at how power operates for the people that we're working with, and also for our members of staff. So we want to really embed these 4 R's across everything. So we're thinking about how these 4 R's, the way that we recognise trauma, the way we resist the urge to re-traumatise people, is embedded in everything that we do. What's the next slide? I can't remember. Is there indeed a next slide? Yes. So this really helpfully outlines the foundations of trauma-informed care. We're talking about from the very, very smallest interaction with somebody. So when they walk through the door of a GP surgery, how are they treated? How could what they're presented with be potentially re-traumatizing for them? How can we make sure that all of our policies, procedures and practices are trauma informed? So by committing to trauma awareness, we're looking to create safety, restore power and build self-worth. So again, we're not talking about mental illness, we're talking about every single person who comes through our doors. So this can involve administrative staff, it can involve cleaning staff, domestic staff, how they create a kind of safe context through a sense of physical safety. So are our service users feeling safe in the services they're using? Are our staff feeling safe if they're going on home visits, for example? Trustworthiness, that we have clear and consistent boundaries, that we're transparent with what we're doing with our service users and staff. Yeah, and that there's some predictability and that there's choice. So that's how we can sort of create a safe concept, thinking about physical security, but also emotional and relational security. So we're looking to restore power through giving people more choice, empowering them to choose pathways and services for themselves, you know, so that they're, but in an informed way. We're working to people's strengths. So, I mean, something that I notice is we would very often, for example, focus on an episode of self-harm in a psychology session. But actually, you know, maybe that person self-harmed only once in the last week and they spent the rest of the time doing really, really well and using all of their strengths to not do that week. So that's an example of how we can refocus what we're working on, not necessarily focusing on problems, but using, you know, working to people's strengths. And we're thinking about building people's skills across the workforce in terms of recognising and sitting alongside people who've been traumatised. And the last bit is thinking about building self-worth in all of those things listed down there. So we're talking about our relationships with people. How can even the smallest interaction be an intervention in a way? So thinking about a trauma-informed organisation that is thinking about every single interaction as some kind of intervention that's going to help somebody on their recovery journey. And those things can only happen if we have the respect and the compassion and acceptance that go alongside, you know, a lot of what all of, you know, I guess all of mental health professionals already do. But it's about labelling it and knowing that this is informed in a kind of, you know, trauma-based way. A final point really is thinking about, yes, the understanding the impact of historical trauma and oppression. So as I mentioned before, thinking about how mental health services have been structured from the word go. They were very, very, you know, they were often viewed as very punitive, controlling, and where service users would often get worse. In, you know, in some services, but, you know, things have moved on an awful lot there, but we need to understand that there is still a lot of stigma attached to accessing services in our communities, and that the impact of historical oppression on particular groups, Black service users, as we heard earlier, and other ethnic communities, certainly in East London, but across the UK. So it's really thinking about the history of oppression and how trauma has been sometimes passed through generations, so that what we're presented with is somebody with multiple generations of trauma at the hands of people who might look like the professionals they're encountering. So it's really, really important. But as we said before, we're not talking about a particular service. This is not particularly aimed at people who would attract a diagnosis of personality disorder, for example, it is really thinking about using trauma-informed lens to view everything that we're doing in the transformation. I think that's enough from me. Oh, a bit early, am I? Can somebody speak to me, Jamie?
I'll speak to you. There's one more slide. I'm not sure if anyone's...
Ah, lovely. Yes, that's great. Okay, thank you. I don't like not being in control of my slides. Okay, lovely. So here's what we're planning. We don't want this just to be bottom up. We want this to be top down as well. So one of the things that we've been crowing about for years is this needs to be in every person who works in mental health social care. So we want to be able to train staff, including management and executives, and it really doesn't work if the executive body is not trained in a sort of trauma-informed approach. We want to really ensure that the embedding of trauma-informed principles goes through everything we do. So we're hoping that recruiting a psychologist roles in trauma-informed care development and improving the training and supervision structures can really help with that process, and also free us up a little bit to be able to listen to what staff and what service users would like from us in terms of trauma. So as well as being trauma-informed care champions here, really, we are also the psychologists who provide complex trauma therapies in East London. And if you look at the secondary care psychological services, you will see that pretty much every single person referred has had a history of trauma of some sort. And it's not, I was driving to the park and almost had a car crash type of trauma. It is really, really huge trauma that has happened to people from birth, and often because of and since their arrival in the UK. So we're really thinking about how we can help people reduce the need for coming into secondary care psychological therapy services, as well as streamline how they can get the care that they really, really need. And we're really pleased that we can finally do this in co-production with peer mentors and people participation leads, and we've got funding for that specifically. So that's a really, really positive development. So we wanted to be on at the beginning of the day, but I guess it's also quite a good place for us to be at the end today.
As I said, Marion, this makes you the headliners, so this is very much the glamour slide.
Yeah, I am the Beyonce of this conference. Yeah.
There's a couple of questions. I'll draw your eye to them, and then I don't know if you want to answer them or if you want to respond to them in the chat. There's one around, I'll read it verbatim because it's really nicely worded. Many of us come into this work because of personal connection with the work, either personal trauma or mental distress in our own families. Do you think mental health staff have generally done enough self-work to be able to respond effectively? And another question, do you want to speak to that one, Marion?
Yeah, sure. Absolutely. I mean, I noticed that when I went into my psychology training. You scratch the surface of a mental health professional or one in training, and you will very quickly get to why they're working in mental health services. I can't comment on whether they've done it, everybody's done enough work. I know certainly that psychologists and psychotherapists generally have had some sort of therapy. I think it's really, really vital. I also think that sometimes the division between people who work as service user or people participation workers and it's a sort of artificial distinction between service users and staff, because I'm a carer, for example. I might very well be a service user, but I might not be talking about it. So I think it's important for us to talk about and acknowledge our own histories of trauma in what we're doing. But yeah, I hope that people get the chance to do ongoing work and are supported to do that, so they can help the people they work with.
Thanks. And another one that's come up is around where it says, can trauma impact mental capacity and make you more vulnerable to exploitation? And do professionals also start a safeguarding process around abuse and neglect, etc.?
Yes, and yes. Yes, absolutely. People who have experienced trauma are much more likely to also experience exploitation or experience other traumas. So people with a history of sexual abuse are more likely to be sexually abused in the future. So yes, that's very, very much part of it. And yes, psychologists and all staff members are trained to make sure they're safeguarding appropriately when people disclose trauma. Does that answer the question? I would hope so anyway.
I think so. And Sinead, either of those questions, anything you'd want to respond?
Yeah, I was just thinking about the last question actually, and about sort of the impact of early trauma and complex trauma over the time of your life. So something that I was trying to explain earlier is about how my mum and dad had a very volatile relationship in my early years, and they were both going through their own difficulties. And what I believe it showed to me was that that love was this constant fighting, this violence towards each other and disrespect towards each other. And then that then had a knock-on effect with how I made relationships later in my life with friends, or, you know, the sense of like having to buy someone's love, having to you know, everything has to be almost like a drama for me to connect to it. And so this in turn meant that I didn't make very good friendships. So then I was like quite bullied and always wanted to people please and stuff like that, which then affects your self-esteem and then makes you vulnerable to things like I was then groomed on the internet when I was about 13, because it was just very, you know, I was an easy target. So then that subsequently led on to how I would then have relationship problems when I was older. So, you know, like it's a horrible thing, because you don't, you know, I don't think this should be about blame towards anyone at all, but little pockets of trauma throughout life can snowball into like quite a serious issue. And that's why it's kind of important to hear people when they're telling you maybe about things that might seem quite small or easy to deal with, what other factors might come in along the way. And you know, I later then went to work in a mental health hospital for young adults, and you know, recognizing about what Mariam was saying about that most mental health professionals that I came into contact with, you know, were there because they also had a personal understanding of mental health issues. And I think a big problem that we face, particularly in our hospitals and stuff at the moment, is that, you know, nursing staff are so underworked that they're having to work very long hours, often going from days to nights, and not getting the chance to reflect on how they feel about having to witness some really awful things sometimes. So like Mariam was saying about how psychologists and psychotherapy, you know, they get therapy and it's a part of the practice to reflect on how you feel about your working relationships with people, but that's not so true in nursing from my experience, and obviously that leads to burnout and to fatigue. So I think it's just important that, you know, everyone who's working on the programme, including, you know, service users and residents, are aware of this and have a mutual respect towards each other. And I would hope that there would be more reflective spaces so that we can work through things collectively. Sorry, I went a bit ad lib there, but yeah.
Fantastic. Marion, do you want to have the final point, and then we'll move on to the next?
Yeah. I guess one of the really positive things about the brain is that it's flexible. So even though the brain can sustain sort of damage from trauma, actually we're incredibly resilient, and that we can be learnt, we can be taught through restorative relationships with others. So learning, you know, learning from other people how to relate safely in the context of a safe relationship from a professional, so that can be really, really helpful, and that we can build resilience. So that's a really positive sort of thought to all this, I think.
Fantastic, thank you both so much. That was fantastic, and there's lots more questions still kind of come through, specifically around trauma. So I don't know if you're able to pick up any of those in the chat box. actually, the final section I'm going to hand over to Richard to wrap things up, really. So he'll take things from here. Richard.
Thanks, Jamie. So we've actually been at it in this session for almost 4 hours now, which seems extraordinary because to me it's felt like an hour. And I just want to say a massive thank you to all of our wonderful presenters who've really brought the work that we're doing to life in such compelling and thoughtful presentations. And I feel personally incredibly proud of the work that we're doing and that we described today, and the energy and passion that a whole range of people who presented today and beyond are putting into it. I just wanted to kind of share 3 takeaways that I've sort of have in my mind as a consequence of what we've heard today. The first is that there really isn't any blueprint for this work. It's a journey, and we're breaking new ground in it, and we're all collectively breaking new ground in it. I think that thinking carefully about the approach to change from the outset in this context is incredibly important. And in our view within ELFT, the change really needs to be developed incrementally, testing approaches from the ground up, scaling up when it works, learning from challenges and problems and disasters. It also will take time. It will take to 2023 and 24 and beyond to really deliver our ambition in full. The second thing, and I just also want to say a big thank you to all of the people participation leads who've presented so compellingly today. People participation is absolutely key. It's the beginning of this work, proper participation where service users really are active and equal partners in the design and the delivery right from the beginning. Marion, just at the end there, you used the word power, and actually that's the first time we've heard the word power in this session today, but it seems to me to be a really important thread running through this work, thinking explicitly about how we can share power, how we give up power when we need to, whether that's between service users and professionals, whether it's primary and secondary care, whether it's health and social care. We haven't talked about inequalities at all in this presentation, but it's a major strand of the transformation for us and indeed in our response to the pandemic. But power is really, and how you distribute it is a really key element of that work too. So putting the time to think about power, I think is probably pretty key. The third point that I just wanted to make, the third takeaway, is that the success of this transformation is not about structures and processes, although those are very important. It's fundamentally about people. And I was just really struck by the way that Moira, the GP in the City and Hackney PCN pioneer, described the importance of the warmth of the approach. And I quote, that you can have gentle, thoughtful, compassionate conversations. It really is a relational approach founded on personal connections that's going to be the key to delivering this transformation. I think that we obviously are living and working in quite tricky and complex and sometimes dark times. It does seem to me that this transformation and thinking about this transformation is that it's an opportunity for a bit of hope and also the opportunity to have a bit of fun along the way. So just to conclude, so we're really keen. So we really don't. We're constantly asking ourselves questions, and we have loads and loads and loads of unanswered questions. We're really keen to work with partners in North East London, in Bedfordshire, Luton, Milton Keynes, in London and the East of England regions and beyond. So I know that colleagues throughout the day have been putting email addresses in the Q&A box. Please do make contact with us. We're really keen to hear people's views and thoughts and help collectively to kind of crack some of the issues, really, the complex issues that we're encountering in this piece of work. I just finally wanted to end to say thank you to Jamie for pulling the session together at really short notice. Actually, we've sort of turned this around in a couple of weeks. So thank you for the coordination behind the scenes, and thank you to NHS England colleagues Nadia, Sandra, and Amy for doing all of the technical stuff that actually has meant that this has come off without any serious technical glitches, which is always a bit of a risk in these things. So I hope it's been a good session. I hope you've enjoyed it. Please do keep in touch and use the email addresses that people have put in the chat. And on that note, I think we're ending. So thank you.